I hope all are safe and healthy staying at home. Sri Ramachandra College of Management is affiliated with Sri Ramachandra Medical College and Research Institute. Since establishment aims to chisel the individuals as multifaceted personalities with ethical values, not only to survive as professionals, but also to contribute their knowledge to the society. As we get ready for the next normal after a period of matchless separation, we must consolidate on recent advances, learn from the mistakes made over the past year, and look ahead. More than ever, carefully considered human decision and collaboration are essential to realize its full potential. This virtual summit is the ultimate platform for pioneers to showcase insight and perspectives on how technology can positively shape healthcare. Now, I request our principal, Dr. Selvam Jasaya, to give the welcome address.
Thank you, Shani. It's my great pleasure in extending the welcome address for this summit. Honorable Vice Chancellor, respected Dean of Faculties, our Director, eminent speakers, and audience of this Healthcare Technology Summit 2021. Dear audience, you all know that healthcare and technology have become inseparable. According to the Indian Brand Equity Foundations, the Indian healthcare industry will grow to $290 billion by 2021. Technology has been playing a big role in this growing story. A high degree of personalization and care has been made possible through use of technology. Having understood the significance of use and application of technology in healthcare, Sri Ramachandra Faculty of Management Sciences, a constituent college of Sri Ramachandra Institute of Higher Education and Research, is hosting this summit, inviting many practicing leaders from industries and academia. Along with this program happening now, SRFMS has hosted about 25 programs since March 2020, the time pandemic broke out. It is our pleasure to welcome Dr. P.V. Vijayaraghavan, our Vice Chancellor, who will be delivering the inaugural address. Welcome, sir. Dr. Mahesh Vakamudi, Dean of Faculty, Srihar, who will be chairing the panel discussion this afternoon. It's our great pleasure to welcome him for this summit. We are delighted to welcome Mr. UK Ananda Patmanabhan, Director, 10X Health Technologies Private Limited, who will be speaking on emergence of intelligent automation in healthcare. Dr. Masood Ikram, Managing Director for Wellone AI, who is instrumental for this summit. In fact, he is our associate and a well-wisher of SRFMS. We have an MOU with him. He will be touching the new norms, need automations, but where should we start? Digital journey for this summit. SRFMS is very glad to have Mr. Gyan Ranjan Mohanty, Associate Director, Accenture Bangalore for this summit. He will deliver his points on trends in EMR. We are pleased to welcome Mr. Jayakant S. Kesan, CEO and Managing Director, Izermet Healthcare Technologies Private Limited, IIT Madras Research Park. He will be sharing his points on smart digital ICU. We take a great privilege to share a dais with Mr. Mohammed Farouk, Associate Vice President, Strategy and Marketing, Dr. Rela Institute and Medical Care, who will share his expertise with you all on clinical intelligence, patient journey, and patient engagement through personalizations. I take great joy in welcoming our Director, Professor K.C. John, who will share an introductory remarks. Our appreciations to Dr. Bhuma and Ms. Nitya Priya for organizing this great event. Wish you all a great event. Thank you so much.
Thank you so much, sir, for your inspiring words and for welcoming the gathering. May I request our Honorable Vice Chancellor, Dr. P.V. Vijayaraghavan, to give inaugural address.
Good morning, everyone. Dr. K.C. John, the Director of the Faculty of Management Sciences here at Sri Ramachandra, Dr. Selvam Jasaya, Principal, Faculty of Management, all the faculty members of the Faculty of Management Sciences at Srihar, honorable speakers, the resource persons for this very innovative program. I'm very happy to formally inaugurate this summit, which is, as Dr. Selvam told, is the 25th of the series of programs that Management College has been doing since the starting of the pandemic. These are days when we have to keep meeting virtually, and we have to carry on with quite a lot of discussions online. I thought I will give certain information, only a bird's eye view of what is the present scenario. And as healthcare administrators in the MBA college, and also I see nearly 170 participants from across the country who have actually registered for this program. It is essential that we keep pace with these developments. The future of healthcare is shaping up very differently in front of our own eyes. It is very difficult for us to believe what are all the advances that have taken place in technology and digital healthcare over the last 4 or 5 years. And now COVID-19 has expedited this process by near necessity. Now, emerging technologies and its impact on healthcare and its economics are broadly brought under 5 themes: artificial intelligence and big data analytics, robotics, 3D bioprinting, nanotechnology and nanomedicine, and cloud computing. So if you are able to sort of push these 5 major themes, you can all write an excellent essay question answer on emerging technologies in healthcare industry, which is the main theme, how it transforms healthcare as a whole. All these technologies have started influencing healthcare through various mechanisms, through faster drug discovery. Today, in the past, if you have to discover a drug, the plan has to be at least a minimum 10 years. But today, with technological advances, it is probably pushed this through, as you can see, the vaccine development. In the vaccine development of corona, I think people have come forward with vaccine in the space of 10 months or 1 year. It has also influenced early diagnosis, precision surgery. Gone are the days when you could err in terms of placing a particular implant or a particular biomaterial. Today, it is precise and it is controlled by the computer to a great extent. Rehabilitation. Exoskeletons have started functioning by means of technology development. And lastly, validated treatment options. Previously, it was empirical treatment. Today, no consultant can ever talk about empirical treatment. There must be evidence and there should be validation. As health professionals I have a few queries. Are we afraid that the robots will take over the jobs of nurses, doctors, and allied healthcare professionals? Are you scared that AI will continue the world will completely change the world in a couple of years? Do we have nightmares about virtual reality, which are addicting the kids and adults of these days, running around with in this dream world? Are you frightened to have a genetic test that will probably reveal the date of your death? These are some of the questions that we are constantly posed with. And the future is not to be afraid that to work hand in glove with technology, and health professionals are only to get benefit. And they must embrace technologies in order to stay relevant in the coming years. I can still imagine many consultants cannot even open a computer, but that generation is gone. The new generation has to be computer savvy and should be able to utilize the various possibilities. In medicine and healthcare, digital technology could help transform unsustainable healthcare systems into sustainable ones, equalize the relationship between medical professionals and patients and relatives, provide cheaper, faster, and more effective solutions for human suffering and diseases, and also in terms of preventive health. Already, rising lifespan of human beings is likely to be further enhanced by all these technologies. And I am very happy to have gone through an article which actually brings up 10 different ways or 10 different commandments in which medical technology is likely to influence healthcare in a very, very big way. First, artificial intelligence. Artificial intelligent algorithms are able to actually mine medical records and design treatment plan or create drugs much faster than any current actor on the healthcare scenario. Virtual reality now is changing the life of patients and physicians alike. In the future, you might watch operations as if you wielded a scalpel from your home, or you can travel to Iceland or any other country on a virtual tour. Augmented reality is another concept. It differs from virtual reality in two respects. Users do not lose touch with reality in this scheme of things and puts information into your own eyesight as fast as possible. Artificial reality, augmented reality and virtual reality will become a driving force in the future of medicine and medical education. Europe and Germany have already advanced in these areas through companies like BrainLab, Magic Leap, and SyncThink. So there are many, many companies which are looking towards all this. Healthcare trackers, wearable and sensors. This is the order of the day. Each one is wearing a watch, which is actually able to measure the fit movements that he is doing, the number of steps that he walks, the number of kilometers that he has covered, the heart rate during his walking. So all these are now possible, which is able to give quite a lot of information to the individual who actually is not a physician, but to an individual who keeps pace with the norms. And the physician remotely is also able to control when things go abnormal. Today, a diabetic can very well be managed remotely by actually the sugar values of the person being measured and recorded on his mobile and being seen by the physician at a distant place, and actually giving him the advice for the amount of drugs that he is to take or the amount of exercise that he needs to do. Medical tricorder is another principle that we have to all embrace. And when it comes to gadgets and instant solutions, there is the dream of healthcare professional to have one almighty, omnipotent device which actually can do everything for him. Genome sequencing is another concept. I think we have advanced quite a bit in terms of tissue engineering and gene sequencing, but the technology is actually moving more and more, and this is likely to give you information about not only the drug acceptability in a particular patient, but also the drug sensitivity in a particular patient. So these are again some of the things that is going to change the whole paradigm shift in the healthcare management. Revolutionary drug development, I already talked about. You can develop drugs much faster. Clinical trials as a principle is also going to change. We are not going to anymore require the so-called thousands and thousands of patients in multi-centric drug trials, but probably we should be able to do a lot of this on virtual labs on the computer itself. Nanotechnology. Nanoparticles and nano devices would soon operate as precise drug delivery systems. You can inject them into the vein, and this can be enhancing and facilitating drug delivery for many of our human systems. Robotics has come already. Robotic surgery is in place in many, many organizations. Surgeons are probably going to be fond of operating from home, corona or no corona, and that is also a huge development which not only allows you to control the surgical aspects, but also makes it very safe and prevents quite a lot of unnecessary complications. Robots are also available to manage ICU patients. While traveling, you can have a complete knowledge of the progress of your patient in the ICU. Now, the last concept is, of course, the 3D printing. It is now possible to print biotissues, artificial limbs, blood vessels, skin, liver, or any organ in the human system. And these will influence the practice of medicine in a great way. While I have just given you a sort of a broad eye view of how one can leverage technologies in transforming new normal healthcare delivery system, the today's program that has been envisaged by the Faculty of Management Sciences will provide a much deeper understanding through the various lectures from the experienced resource persons like Mr. Ananta Padmanabhan, Dr. Masood Ikram, Mr. Gyan Ranjan Mohanty, Mr. Jayakant Kesan, Mr. Mohammad Farooq, and also our own COO, Dr. Mahesh Vakabudi, during the panel discussion, which is likely to be very interactive. The program would definitely sensitize our young budding health administrators towards the future healthcare administration. It's going to be totally different. You cannot sit in your chair and start administrating various areas in the organization. I must at this point tell that the Faculty of Management has been progressing very well over the last 2 to 3 years. We have increased our intake of students in MBA from 30 to 60, and we are training them under 3 different verticals of healthcare quality, human resource development, and also healthcare financing. I'm sure the way Dr. John and Dr. Selvam are actually helping us, this business school is going to grow into a general business school, attracting hundreds and hundreds of students to begin with. Now, it is my also duty to inform all the participants, because I think there are participants from outside Ramachandra as well, that you are into the portals of a quality organization, which has always cared for quality initiatives. And we have consistently participated in several accreditation mechanisms. Our medical center has been repeatedly accredited by both the Joint Commission International as well as by the National Accreditation Board for Hospitals thrice over, and we maintain quality standards and patient safety as a theme. We also, as a university, participated in the National Accreditation and Assessment Council almost 3 times over, and the last time we have been given a score of 3.53 upon 4 with a A++ category, which actually allows us quite a lot of academic flexibility in order to introduce newer and newer programs. Today's media has already been talking of quite a lot of business programs happening completely online, even to the level of degree programs. And I'm sure the Faculty of Management Sciences will take clue to make all these advances and all these changes. I am extremely happy to formally inaugurate this program. Have a wonderful time. Wish you all the very best. Thank you.
Thank you so much, sir, for your illuminating speech. It was extremely informative. I humbly invite our director, Dr. K.C. John, to give introductory remark.
Thank you. Good morning, ladies and gentlemen. Thank you, Dr. Vijayaraghavan, for such an inspiring message of how emerging technologies will shape the new normal of healthcare management. I wanted to be a devil's advocate and talk about few things which will not be discussed during the seminar. The COVID-19, once in a century health crisis, has not just laid bare the myriad challenges and gaps in our healthcare systems, but also highlighted the importance of investing in well-being at both personal and system level. It has ushered in an era of digital and technological innovations and advancements, which we call as AIM Lab. A for artificial intelligence, I for Internet of Things, ML for machine learning, A for advanced analytics, and B for blockchain. This creates patient-centric treatment and enhanced patient experience. Let me highlight a few significant technological advancements which has helped us immensely in our fight with COVID-19. Number one, success in vaccine was absolutely extraordinary. It has never been the case that in 12 months, alternative sets of vaccines were developed, tested, approved, and rolled out for entirely new disease. We have now an accelerated platform for vaccine development for future pandemics. In the big data era, artificial intelligence and network medicine offered cutting-edge application of information science to defining disease, medicine, therapeutics, and identifying targets with the least error. Virtual care, telemedicine calls came to rescue of patients as they sought to safely obtain outpatient care. India's healthcare fragility and weaknesses have been exacerbated over the past 2 months. As healthcare organizations grapple with response to the pandemic and adapt their operations to continue to fulfill other aspects of their healthcare mission, they must also define and prepare for the future of care amid economic, regulatory, and social uncertainties. And that's the context in which this healthcare technology summit should be viewed. We have assembled expert healthcare practitioners from leading healthcare systems. They will present their point of views and help us define the new normal health technology agenda. I welcome all. The COVID-19 wave 2 laid bare the weakest links in the healthcare ecosystem, namely the primary healthcare. The present structure of the primary healthcare system is 80 years old, designed by Sir Joseph William Borde, who led the committee in 1943 to design this primary healthcare system. Its limitations are well known and include it's not accessible, is personnel intensive, is expensive with limited returns, does not provide required services, and does not address the cause determinants of disease. Universal primary health care can be achieved when artificial intelligence-based primary health care can be delivered at a person's home continuously and comprehensively. This can streamline the rest of the healthcare system as well. Institutions like Arvind Eye Care and Sankara Nethralaya have demonstrated use of the internet and satellite communication technology to communicate with their mobile units sent to rural areas for provision of screening services, particularly for diabetic retinopathy. Saving and restoring vision through early screening for diabetic retinopathy and diagnosis and management of cataracts and glaucoma have exhibited the effectiveness of innovative solutions in eye health care. Given that high percentage of Indians live in rural areas and tier 2 and tier 3 towns, primary care is the most important need for the population. Access, assurance, and affordability are the key word in a series of primary healthcare innovations attempted by collectives of not-for-profit, for-profit, and government agencies in Tamil Nadu, Karnataka, and Maharashtra. Certainly, we could embrace the lessons learned from these initiatives to provide affordable primary healthcare to all. The volume of telemedicine calls increased dramatically as patients sought to safely obtain outpatient care. This increase occurred over a noticeably short period. Providers hastily constructed a temporary bridge built with digital tools and operational workarounds that are not robust enough to sustain increased level of call permanently. At the same time, patients have come to expect telehealth, and many doctors have become comfortable delivering care via the technology. Because virtual care is now part of the new normal, healthcare systems must construct a sturdy, permanent bridge that includes organizational, financial, and clinical structures and processes to provide enhanced patient-centric experience. The National Digital Health Mission envisions to create a national digital health ecosystem that supports universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner through provision of a wide range of data, information, and infrastructure services, duly leveraging open, interoperable, standards-based digital systems, and ensuring the security, confidentiality, and privacy of health-related personal information. The healthcare system will need to integrate telehealth technology with electronic health record, define clinical protocols for appropriate telehealth visits, obtain reimbursement for telehealth visits, and revamp hospital and physician practice and processes to support telehealth. During the peaks of the pandemic, health systems dramatically increased the speed of their decision making to contend with challenges such as shortages of oxygen and personal protective equipment, the high utilization of intensive care unit beds, and protocols for safely treating patient and protecting staff. Acceleration has been the pandemic's most notable impact on health systems' digital strategy. The time frame for accomplishing initiatives to pursue telehealth, improve the patient experience, and reduce the cost of delivering care were significantly compressed. What might have taken 10 years to accomplish will now take 1 year. While this public crisis has tragically cost us lives, livelihoods, and our sense of normalcy, we still have the power to shape what comes next. COVID-19 has forced healthcare leaders and clinicians to move faster, work smarter, and make a more focused approach to decision making than ever before. Digital health solutions and technology will play a crucial role in the difficult work of optimizing processes and systems for greater efficiency, financial viability, and enhanced outcome. Through this unexpected disruption of the status quo, there is a tremendous opportunity to create a new normal that is a significant improvement over the old normal. I look forward to an intellectually stimulating deliberations, and I take this opportunity to welcome again all the distinguished speakers and panelists, as well all the participants who are with us. Thank you very much.
Thank you so much, sir, for such an uplifting opening remark, a good message to start a meaningful session. It's my privilege to propose the vote of thanks on this occasion. I, on behalf of Faculty of Management Sciences, would like to extend a very hearty thanks to our Honorable Vice Chancellor for joining us virtually and enlightening this event. I would like to express a sincere gratitude to our Honorable Director and Principal for your constant encouragement and support. Now, I would like to invite Dr. Bhuma Devi, Associate Professor, Faculty of Management Sciences, to give the theme introduction.
Thank you, Karen. Good morning, one and all present here. My respect to all the dignitaries. Let me take the privilege and briefing about the theme of today's Healthcare Technology Summit, leveraging technology in transforming new normal healthcare delivery system. So this COVID-19 has encouraged technology innovations that are changing our world. We chose this topic to know whether organizations are ready to seize these new opportunities. While there is no minimizing the devastating human and economic impact of the COVID-19 crisis, we have to believe that with every downside, there is an upside. The crisis has undoubtedly accelerated digital transformation across the world and opened our eyes to the possibilities offered by technology solutions to enhance and support our lives and sustain and grow our businesses. We may believe there is no going back to the old normal and that the new normal is here to stay. The pandemic has propelled organizations toward redefining their new normal. Barriers that were previously in the way of technology transformation have been found wanting without the option of alternatives. Our unusual circumstances have encouraged us to reflect on this theme, technology transformation, we can expect to see in the sessions ahead. I would actually thank all the speakers who have readily accepted in their busy schedule to share their expertise in the area which they are passionate about. Today, this summit is divided into two parts, one with a speaker session and the next part will be the panel discussion. In the first session, we'll be having Mr. UK, so we call him UK Sir, who may look aged, but his thoughts are very young and innovative. Mr. Dr. Masood, who is passionate in AI, Mr. Ashwath, who is going to talk about P4 medicine, which is a very new concept. I'm very eager to hear from him. He represents Accenture. Mr. Jaykant from ZMed, he is also a young entrepreneur. He is very passionate. He is also very passionate and has done research using technology in healthcare. And Mr. Farooq, he is a very humble person who is readily accepted, and he is an associate director in RELA International Divisions. And let me now call upon the youngest faculty of a college, Ms. Nitya, to introduce the first speaker of the summit. Nitya.
Thank you, ma'am. It's my immense pleasure to introduce Mr. UK Anantapatmanabhan. He is one of the senior-most professional hospital administrators in the country. During his long career of 3 decades in the healthcare industry, he has held various top positions in large hospitals like Apollo, Goa Medical Center, Continental, Meenakshi Mission, Shankar Netralaya, Haveri Hospital, Sundram Medical Foundation, Rainbow Hospital, and MGM Healthcare. Planning and designing the healthcare information technology solutions with emerging technologies like Internet of Things, cloud computing, artificial intelligence, and machine learning has been his forte. He is now on the advisory board of MGM Healthcare Group, Chennai. He is also the director of healthcare IT startup company 10X Healthcare Technologies Private Limited, Coimbatore, which is involved in design, development, and implementing hyper-automation solutions to hospitals. He is actively involved in teaching, training, and research in the field of management, and is now a visiting professor for many postgraduate institutes and universities. He is a graduate in electrical and electronics with a post-graduation qualification in business management, hospital administration from NIGA. As part of his CSR activity, he is running a campaign called And Wash Indian Campaign for the past 4 years for teaching and training the poor children in India on the importance of hand washing with soap. We welcome you, sir.
Thank you, Ma, for such a generous introduction. Are you able to hear me clearly? Are you able to hear me?
Yes, sir. Can hear you, sir.
Oh, good. Can I share my screen, please? Are you able to see my screen? Are you able to see my screen?
No, sir.
Hello?
Hello? No, we're not able to see your screen.
Not it?
Not yet, yeah.
Yes, yes, sir.
Yeah, 1 second, please.
Yeah, we are
Yes,
able
sir.
to see your screen.
Yeah.
Is visible, sir?
Oh,
Yes.
good. Good morning to everyone, and I thank Ramachandra Medical College for inviting this wonderful healthcare technology summit. I'm a proud visiting faculty of Ramachandra Medical College healthcare department, and I have also had the privilege of guiding the students of healthcare MBA and Health Informatics Department for the project internship. The topic that is to me is very close to my heart, and I'm happy to share my thoughts and experience in this field. So the topic which I'm going to talk about is about emergence of hyper-automation for COVID care of the future. In fact, I just modified this topic a little to fit it into the context of what today. So very quickly, we must go from the lessons we have learned from COVID-19 pandemic before we jump into hyper-automation. As everybody spoke in the inaugural session, COVID-19 was unprecedented and hit us like tsunami. Patient load in the hospitals increased by about 400% during the COVID-19 second wave. Indian medical infrastructure crumbled under pressure. Indian healthcare was planned and poorly funded and managed for over 70 years, and hence it became very vulnerable. It destroyed many lives and livelihoods. It also changed the way we work and live. It brought to focus the need for very agile, flexible, cost-effective, and efficient health facilities. This accelerated technology adoption in hospitals by 10 years. No doubt, because technology was being adopted in other industries like factories, maybe malls, educational institutions. Healthcare did not adopt in the pace other industries adopting. And I think this lead us to why we need to have hyper automation. And before we go to hyper automation, it is customary to talk about the four industrial revolutions that happened. The first industrial revolution happened in the 19th century, where the mechanization started, and this water power and steam power. And then early 20th century, we had the second industrial revolution with mass production and assembly line, with electricity being invented. Then we had the third industrial revolution when the computer and automation came in, that is in the late 20th century. You just see there was almost about 200 years gap from the second revolution to the third revolution. But during the current revolution, we are talking about the fourth revolution, cyber-physical systems, the era of artificial intelligence, machine learning, and low-code and no-code platforms. This is the present fourth industrial revolution. But I think 4.1 will happen in another 5 years, 10 years time. So what did Accenture? I have a friend from Accenture who is going to talk today, and he said, the CEO of Accenture said that half the Fortune 500 companies vanished after the year 2000 because they did not adopt digital technologies. Now I think with what he said, it is time for us to wake up. 53% of the companies are already using machines in place of humans. This is what the Deloitte survey says, and the figure is expected to come to about 72%. And Kai-Fu Lee, the artificial intelligence and artificial superpowers, he is an ex-Microsoft and Google, says that artificial intelligence will eliminate 40% of the world jobs in the next 15 years. And then the Foxconn chairman, he says that we plan to replace 80% of the workers with robots in the next 5 to 10 years. So with this background, let us understand what is hyper-automation. I am a great proponent of hyper-automation in hospitals, in healthcare. Intelligent and hyper-automation is the application of advanced technologies like artificial intelligence, robotic process automation, Internet of Things, real-time location tracking system, low-code platform software for automating all operations in the operations and processes in the hospital, whether they are clinical or non-clinical, end-to-end in a healthcare facility to augment human effort and ensure operational excellence. I think you must mark this word. That is augment human effort. It is not going to replace doctors. It is not going to replace nurses. It's not going to replace technicians, but definitely maybe help them, maybe supplement their efforts in taking care of the patients. And for people like me who have been in the industry for quite some time, I have been working in the hospitals for over 25 years, and I have seen the manual operations. I have seen some computerization in the hospital, and now I am seeing the trend of hyper automation or intelligent automation. And to me, hyper automation or intelligent automation is a magic wand in our hands. I'm very clear about it. But it may be the panacea for most of the ills in the hospital, but we must be ready to bite the bullet. We must be prepared to spend on technology. We must be able to understand technology. We should do the change management. Then only it will work as a magic wand. Now people are simply talking about hospital information system, EMR, PACS, and telemedicine. I think a time has come, the defining moment has come when we have to look beyond hospital information system, EMR, PACS, and telemedicine. So what are all the technologies in hyper automation? There are over 20 technologies in healthcare IT, which are convergent and which are doing a great job in the healthcare industry. But to me, these are the 5 real emerging, innovative, cutting edge technologies. They are low code application platforms, Internet of Things, robotic process automation, real time location tracking, artificial intelligence. These are all the 5 technologies which are really making a difference in the hospital operations today. Then I think we should look at the hyper automation framework in a hospital. If you look at the top 4 patient management services, where we talk about admission, transfer, discharge, billing, more of administrative functions, it is computerized already. Then you have clinical services like HIS. In HIS, you have EMR, PACS. Then you have enterprise resource planning systems like for HR, financial management, and materials management. Then you have customer relationship management, the CRM. But these are all legacy systems which are already existing. But unfortunately, not even 10% of the hospitals around the country have a good HIS. And why talk about EMR? Not even 2% of the hospitals have EMRs. Now that is a question to be debated. But having said that, that does not stop the other technologies going forward. So the other technologies which I have listed, like workflow management, where we can track assets, we can track patients, we can do insurance processing through RPS. Then we are talking about IT-enabled supply chain system, where the supplier can have a vendor portal and he can put in the invoices, send materials. Then we get the information in the hospital portal, and we can create clearance automatically. Then use a low-code platform to close the entire cycle of supply chain. We are going to talk about it as we go along. Then we have doctor and patient engagement. We have mobile apps and we have chatbots. Very interesting. I'm going to show you some case studies as well. Then we are talking about IT infrastructure and network services. We were having IT infrastructure. Maybe we are having switches. We were having LAN switches. We are having Wi-Fi switches supplied from many reputed companies. But they were more into LAN. But now we are talking about wireless technologies, innovative and cutting edge technologies like Wi-Fi, LoRa, and 5G. And then last but not the least, the hospital building management system. Not even 2% of the hospitals have a good building management system. But now I think there is going to be a leap frog in terms of building management with IoTs coming in. IoTs are cheaper, easy to implement, faster to implement. So IoT enabled building management systems, energy management systems. So very quickly, what is a low-code application platform? I think low-code application platform is a technology. To me, the defining moment has come in the software development industry. And this low-code application platform is a platform that supports the rapid development of applications, IT applications, one-step deployment, and it is a high level of programming abstraction. Now today, you don't have to depend on professional IT programs. Professional IT programmers to build your applications. Maybe they have so many applications to build. So if you ask for a customization, if you ask for a configuration, it takes quite some time because they are overloaded. But today, with this concept of low-code application platform, the process owners, business owners, maybe you're talking about a purchase manager or a stores manager or a finance manager or even an HR manager can develop his own IT applications with very limited knowledge. Please understand, they need to have only domain knowledge, very limited IT knowledge they need to have. And the concept of citizen programmers is catching. The concept of citizen programmer is a movement that is happening People like us are educating people. People like us are evangelizing the concept of citizen programmers in the hospitals particularly. And according to Microsoft, I saw in one of the videos, 65% of the software applications are expected to be on low-code application platform by 2025. So there are about 200 low-code platform vendors around the world. But I have just listed out top 10 low platforms which are really revolutionizing the software industry. And what is very interesting and what is gratifying to know is that Zoho Corporation is one of the Indian companies listed in the Magic Quadrant, and they are the third in the list. They are doing extremely well, and I have been using the Zoho Creator platform to do a lot of applications in the hospital, and especially during the COVID situation. I think it came very handy. It came very handy. You see a Gartner Magic Quadrant. Zoho is in the challenge segment, and they are doing extremely well around almost about 150 countries in the world. So what are the low-code applications which I developed during the COVID-19 pandemic? We were able to develop a building management system, asset tracking management system, environmental management, transportation management, workflow management, quality and safety management, business development management. All the applications we were able to develop in 1/10 of the time what a professional IT programmer would have done. And we were able to implement them very fast. Each of these applications have about 5 or 6 modules in it, and each of the modules have about 10 or 15 features in it, and you will be amazed to see how it works. Why low-code platforms? Low-code platforms require very little coding effort, very little IT skills, but require a very good domain knowledge. It is 10 times faster to develop a software application, 50 times cheaper than a conventional software. Very less time is required for training and implementation of the software. And the evolving concept of citizen programming is really accelerating the use of low-code platforms. And I personally believe in the next 5 years, low-code software skills may become the necessary condition for employment. Like this HR managers now asking every employee who is coming in, do you know Excel? Do you know advanced Excel? Do you know how to work with internet? Do you know net banking? And when they ask for such skills, in course of time, they'll be asking whether you have low-code software skills for a particular department. So let us look at robotic process automation. Robotic process automation again is a very interesting technology. I think it has revolutionized. I am again a great fan of RPA, and robotic process automation is a software technology utilizing the software robots to emulate human execution of business processes. It captures data, runs applications, triggers responses, communicates with the other systems to perform a variety of tasks. So these are all some of the applications which I have been personally involved in developing, and we are in the process of developing. It's also interesting to see that many hospitals in the country, like Rainbow Hospitals, Max Healthcare, Kaveri Group, and MGM Hospital, have started using these robotic applications in their daily routine. The examples are the services invoice processing for maintenance, maybe IT, marketing. Whenever these invoices come, it goes through the manual process of certification, then passing it on to the accounts department, then entering it to the tally. All is done seamlessly. All is done very smoothly from the time it comes from the vendor to the time it goes to the finance department for approval and enter into the tally. Then we have GRN preparations. You must understand that when we receive materials, we prepare goods note when they are seeing the invoice. We prepare about 1,500 GRNs a month in a hospital, 300-bed hospital. If it's a group hospital, maybe of 10 hospitals, you are talking about 15,000 GRNs was being manually prepared by some of the materials assistants. But today the RPA has come into use, and you will find that when the materials come in the morning, maybe you get about 40 invoices. These 40 invoices are processed in the night, and next day morning the GRNs are available to you. And Rain Hospitals, Hyderabad, is using extensively. Max Healthcare is using it for their GRN and invoice and also insurance processing. And insurance processing is a very classical case which is being used, I understand, in hospitals like Kaveri Hospital also, and they're also trying to use. There will be about 1,000 insurance claims that come into the hospital, and it is a very tedious process, time-consuming process. It is also on the front end of the patient, and patient is annoyed when the insurance claims are not processed. Pre-authorization can be done using RPA, then processing the bills, following up payment can be done. Outpatient registration, I'm thinking that this is going to be again a very interesting area. We get up 500 outpatients a day with using the KC, and just using OCR techniques, using this RPA, we will be able to register the patients very fast, especially in camps, especially when we are doing COVID vaccinations, when we get 400 to 500 people for vaccination. Data migration in healthcare was an extraordinary example. In our hospital, we moved from one vendor to another vendor. When we changed the IT vendor, we had to move 30,000 patient records, and if we had to do it manually, it would have taken 5 people almost about 2 months, but we were able to do it in 10 days by using this R tool. And of course, the email processing classification, maybe in hospitals like us, we'll get about 200 emails, and each of these emails have to be classified for leads, and then maybe download the assignments, and all this now is being RPAs are being now used. The service provider credentialing, again a very interesting application, where when we credential the doctors or nurses at work in the HR department, we have to check in the website whether they are registered, whether they have a qualification, whether their qualifications are recognized. All is done through this RPA. So this is a simple RPA framework, and you see so nicely depicted. You have bots on this side. You have the as the mail comes, the mail is read by a bot. Then the data is extracted by another bot. Then it goes to the rule engine, and from the rule engine, then everything is mapped, and then it goes to the dashboard. And this invoice or any document can be again done three-way matching. You can do a three-way matching of the GRN, the invoice, and the purchase order, and you can create the GRN and also arrange for payment using the HIS, which is available. So this is a very clear. It is something like a genie inside a bottle. So you put a genie inside the computer system. So this Internet of Things again is very interesting. Many people talk about it, but few people did. But people like us have really used it, and we have found the value for that IoT integration into our system. And these are all IoT devices. Like you have a drip rate monitor. I'm going to show you a little more of it later. And then it's a temperature sensor for blood bank refrigerator. These are water consumption meter, which we can track and then get it onto the IoT platform. And this again a temperature sensor. This is a BLE. These are all BLE sensors which are used on the patient, which is used on the employee, is used on the equipments, and we can even measure the temperatures by fixing them onto the walls. And what you see in the second row are all gateways. We have gateway, LoRa gateway, we have RS480 gateway, we have GPS gateway. We don't have to know much about those gateways. It's all a technical jargon, but we will leave it like this. But it is very essential to know that in the IoT system, gateways also play a very, very important role. So I told you about the IoT enabled monitor. This is a drip monitor developed by one of the startups, and he was awarded as well by the CAO. And then we also have companies like Zoho, which have created we have developed this IoT enabled drip monitoring system. I feel it is a very, very good system, and we have not understood the value of the system. People like us have been working in the hospital, and we know how much trouble it causes to the nurses. Suppose you have a ward of about 25 beds, and if 20 IVs are happening in that ward, the nurse has to keep track of the IV fluid level in each of those IV bottles. And every time she will rush to the room to find out, she would have at least walked 2 times to find out whether the IV fluid is there or not. Otherwise, the patient relative has to run up to the ward station and say that IV fluid is not there, and they have to come and change. So with that scenario, it gives you a reliable drop sensing. It monitors, and remote monitoring through this through this iPad is possible. And you find that this is the patient, and all these details are all captured in the iPad, and it is in the ward station, and you can even take it to a server. Just imagine if you have got 300 patients in the hospital, if about 150 infusions are happening, we can remotely monitor the levels of infusion. And this reduces the nurse's workload and improves the patient safety and also helps in audit reporting in case of medical legal issues. And again, a very interesting case study actually during the COVID-19 situation. We had COVID wards, we had COVID ICUs, we had COVID surgery theater, and we wanted to measure the temperature and humidity, and nurses were finding it extremely difficult to do the they were wearing the PPEs, and whenever the temperatures change, whenever the temperature beats the normal values, they had to call the maintenance people. Maintenance people were afraid of coming. They had to change the dress and then come inside. But what we did was, instead of manually recording it once in the morning, once in the evening, and the nurses had to go and supervise those records, believe me, there are about 15 equipments like refrigerators and 50 locations like operation theater, intensive care units, laboratories, where the temperature and humidity has to be monitored and is also regulated by NABH. We are supposed to maintain a record like this and show it to them. They were all doing manually, but what we did was we put IoT devices in all those rooms, like operation theaters, laboratories and ICUs, and also put IoT devices in the refrigerators, blood bank refrigerators, even the food storage, cold storages, and we connected all those devices into our low-code platform, and we were able to get data like this. Just imagine sitting in a control room. It is something like Kerala government putting up an oxygen control room. It is something like Tamil Nadu government putting up an oxygen management room. And we are able to see a war room inside the hospital, where you can see all the, and I have listed only the operation theaters. Now I'm just listing out some of the nursing station refrigerators, but like this, there are about 50 locations for the equipment, 50 locations for the room temperature. We are able to monitor this. The two great advantage of this is nobody need to inform the maintenance department that the temperature gone up. So this is visible because the data is democratized, data is federated. So there, everybody is able to see through this platform. And even before the nurse complains, and the maintenance guy is able to attend on to this. And we are also able to conserve energy. In some places we find that people maintain 19 degrees centigrade when you have to maintain 22 degrees centigrade. Please understand, 1 degree of temperature can amount to about 8,000 rupees per day in a large hospital. So 3 degrees can mean about 24,000 rupees. So it is definitely an energy conserving measure as well. So we have now ambulances. During the COVID situation, we had put this GPS enabled IoT devices in all our ambulances and vehicles. Believe me, we transport organs from the airport to the hospital, and we have to track the ambulance. We have to track the time that is taken, and then we also have to track the COVID patients' ambulances and all that. So when we did that, we put all the IoT enabled GPS trackers, and we were able to know where all these ambulances are staying and how they are moving. We are able to see all of them there. And these data is into the low-code platform, and we're able to get a complete picture of the number of trips that were made, emergency trips that were. And just imagine, if I am having five ambulances, I'm able to get all these data, the number of trips, the number of emergency trips, routine trips, service trips, free trips, paid trips, total kilometers, emergency kilometers run for emergency, run for routine. When I say run for routine, we may be dropping a dialysis patient and picking him up. Then what is the total amount that is collected? Believe me, if they have to do it through HS, it will take a long time. Believe me, if they have to do through Excel sheet and present it in a BR meeting, it will take a long time. But this is a great tool in the hands of the people. Then this IoT enabled asset performance monitoring. Again, I am a great fan of this. Just imagine in a hospital like a corporate hospital with about 300 beds, there will be at least about 50 monitors, cardiac monitors. There will be about 10 or 15 ventilators. There will be about 200 infusion pumps. These pumps, we don't know where they are located, whether they are working, how much they have earned hospital, we don't know. So what we have done is we have put an IoT device on these equipments, and using the drivers from these equipments, we are able to know whether they are working, whether they are in the working condition, how long they work for a particular patient, and we know this is a classical report we get from that kind of equipment. In fact, Zeblis is doing an extraordinary work. We have also tried their system, and we are able to not only extract vital information from the equipments like ventilators, monitors, and then do charting solution, but we are also able to monitor the utilization of these equipments. We are able to see the type of device, what is the model number, what is the equipment code given by the hospital, what is the device name, what is the MAC ID status, whether it is working or not, then what is the patient ID, what is the patient name, where is it, whether in the medical ICU or which ICU, when, how, all that we are able to see. And just imagine if you are able to keep a track for about 200 equipments like this in that so-called command center, I think it will be a great achievement. And in fact, I recommend even Tamil Nadu government or central government should have this kind of a system where all these equipments which they give to all the district hospitals and the government hospitals should have this system, so that the director of medical education or the director of medical services should be able to see whether these equipments are there, whether they are working or not. So real-time location tracking system again is a wonderful technology. Not many people know it. Real-time location tracking system is also known as the inpatient in-house positioning system, where it's like GPS. GPS is for locating an object or a person or a vehicle outside a building, but real-time location tracking is indoor positioning system. So in this, this is the technology we have. This device I told you, these are all the devices. This beacon tag sensors, it is put patient, it is put on the employee, and then this through this gateway, then through from gateway wireless network. That wireless network can be a LoRa network or a 5G or maybe a BLE Bluetooth low energy network 5.0, and then it goes to the cloud location engine, and then from there you're able to see the dashboards. We definitely not explored the benefits or the value that this technology can derive, and some they believe that it is expensive, but the IoT prices are coming down and the technology is available on a SaaS basis, so we must be able to use it. And so in fact, the pilot which we did in Coastal Center, we put about 100 such BLE tags on the infusion pumps and syringe pumps, and we also put some tags on the patient and their employees, and we were able to track. And this is the kind of tracking you get. So nowhere you can get this information manually. This is a typical RTLS equipment tracking dashboard, where you find we know this particular asset, it was in the emergency triage area, and then it's there, and then it is connected to a patient who comes to the triage area. There the triaging, then it goes to the ER ward, and then the patient is left there. The infusion pump comes back to the emergency triage area. This is a typical tracking of a particular cardiac monitor or an infusion pump that is there in the ER triage area. And we can also track the patients. You have master health checkup patients. When you have 40 master health checkup patients coming to the hospital, they go to about dozen places. They go to consultation room, they go to ECG room, they go to X-ray room, they go to even cafeteria for taking food, and then coming back for giving post-paral sugar. Then there's master health check lounge. They stay in the reception area, come for some inquiries. We can track every movement of that patient and track for every second of the patient, so that we are able to optimize their waiting time. We are able to optimize the technician time. We are able to optimize the utilization of the equipments like CTs, like your ECG machine, your X-ray machine, your ultrasound machine, and all that. So this artificial intelligence, I don't want to talk much about it, but because many people are going to talk about it now, but it is I also believe that artificial intelligence will not replace doctors. Artificial intelligence won't replace doctors, but definitely doctors who don't know about artificial intelligence will be replaced in the future. So that is the message we get. And in fact, I have been listening to people like Elon Musk. Elon Musk says that the day of solidarity is going to come. Solidarity is the day when the artificial intelligence overtakes human intelligence. So you will find there will be robots in the factories, and a day will come when the HR managers will be mandated. HR managers will be mandated to recruit digital assistants as well as human assistants. Just imagine if a requisition goes from the finance department to the HR manager, say that I want 10 assistants for the new hospital. For the new hospital, 5 should be digital assistant and 5 should be human assistants. So the job description should be given to the digital assistant, job description should be given to the human assistant as well. So what AI is getting machines to think like humans. It can learn, it can understand and adapt. And yeah, this is a very interesting post I saw when about 100 years ago, when automobiles came in, replaced horses with the carriages and all that. The horse owners were very upset. They said horses won't stop, but machines will stop. The automobiles can be very expensive, and it will never see the light of the day. But what happened? Horses went out, and automobiles came in. From automobiles, we had cars to scooters to motorcycle lanes, and I think that's exactly that is going to happen between humans and artificial intelligence. I don't know whether humans will be replaced by artificial intelligence, and that day will happen on the day of solidarity, as predicted by Mr. Elon Musk. But sir, in fact, I heard a video yesterday. He says that there must be regulation in AI, like you have IRDA, like you have maybe for atomic research, you have regulatory authorities. You must have regulatory authorities at the international level for artificial intelligence. Otherwise, the AI will go berserk and be utter chaos in the community. That is what he says. And people like Sundar Pichai, Nadella are all promoting the concept of regulation in artificial intelligence. So finally, just about 3 slides I have. AI is all around us. AI assistant medical diagnostics. In fact, I was listening to Dr. Matthew Cherian of Covey Medical Center in one of the presentations where I've also participated. He said that 200 CT images were processed a day. It was going through artificial intelligence software in COVID-19 situation. He was saying if this each of these CT image, if it was done by a radiologist, will take about 20 minutes. But he said it was able to do within a matter. IA was able to do in about 3 or 4 minutes. But to him, I'm used to seeing 40 scans and 50 CT scans in a hospital. I was working in Covey Medical Center for a long time. I know the entire hospital. But to do 200 CTs during COVID-19 was really a great surprise, and AI is going to help in that matter. I also listened to one of the presentations by the Bombay Municipal Commissioner, who said that they used artificial intelligence to evaluate the X-rays in the Mumbai Municipal Corporate when COVID situation was very bad. So you are going to see voice assistants like Google Assistant and Alexa doing much more than what it is going to do today. And then computer vision is another great technology, but for the passage of time, I'm not talking about it. Facial recognition again is doing is really useful for social distancing and maybe tracking. It is possible. So there are only 2 more slides. What are the drivers for hyper automation? With all my experience, I found the drivers for hyper automation is the COVID-19 is an urgent. With COVID situation, there is a need for agile, flexible solutions, IT solutions, and so you cannot wait for 2 months. They did not give us 2 months to develop all these solutions. They just give us about 5 days and 6 days for each option, and we developed it. Then the emerging technologies came very handy, like artificial intelligence, machine learning, IoT, RTLS, low-code programming came very handy, and they were great tools in our armor, and we were able to do it. And then now we have lack of skilled software professionals. We have a lot of graduate engineers. We have a lot of software professionals having degrees and diplomas and certificates, but I wonder whether they have the adequate skill sets to do this work. So the lack of adequate skilled software professionals is again a driving force. And then reducing cost of IT software and hardware. Like the prices came down in mobiles, the price of IoT devices are coming down, price of cloud storage spaces are coming down, and the SaaS model is coming in. So the reducing cost is also one of the drivers, and changing customer perceptions and expectations. I think today a patient does not want to wait 5 minutes in a cash counter. One is he doesn't want to strain himself. Another is he's also afraid of the COVID. So he wants to be with very, very less time. He wants to be in the hospital. So the customer expectations, perceptions, and shares. Many people look at Ola, Uber, Airbnb, and cloud. They don't want to pay upfront a license cost of 5 lakhs or 10 lakhs. They just want to pay an implementation fee, pay on the OPEX model, and that is the beauty of this low-code platform and RPAs and all that. And finally, the central government and state government initiatives also helped. Maybe 5 years ago, 10 years ago, government was nowhere. But today, whether it is in banking or in e-governance, smart cities, oxygen war room by Kerala government, Tamil Nadu government, Karnataka government made all the difference. And I think the last best thing that happened is the NDHM, the National Digital Health Mission, which will definitely integrate all hospitals, will integrate all service providers, will integrate all the patients, then unique health ID like the Aadhaar ID. Last slide. These are all the challenges. You may ask me, Ardharam, you have talked so much about it. You claim that you have implemented so much in many hospitals. What has been your journey? What has been your experience? But I must tell you that this is must be a top-down approach and also up and bottom approach. But somewhere I still feel I could have got better support from the top leadership, better understanding. But maybe in the hospitals where I have been working, I've been fortunate. See, whether it was in MGM Hospital or Kobe Medical Center or Kaveri, people were wanting to do this. They were forcing us to do this. They were always saying, okay, we'll have an innovation team. We will talk about centers of excellence in the hospital. We will have a task force to do it. And I should have such leaderships. And maybe people like us have been fortunate, but I have also seen some hospitals who are afraid of adopting. I don't know if they are the top leadership does not know what is in it for them. So I think that is the problem. Maybe collectively there must be a lot of emphasization of this at the top level. If we can that, I think the hyper automation or maybe intelligent automation may become a reality. Change management again at the lower levels, at the management level, the legacy systems are there. People don't want to change, but people like us must work without getting maybe sidelined or insulted or insinuated, but we must keep on pursuing this, and change management is just not easy. Then many people have the fear of losing jobs. At the back of the mind, if I implement this hyper automation, I may lose the job, but I want to tell them they won't lose the job, but they'll have to change the way they are working. So as somebody said, hyper automation will not displace jobs, but it will transform the jobs. And we must learn to reskill, we must learn to relearn, we must learn to upskill ourselves. Then there is no fear of job. Then lack of transparency is again a great challenge. EMR, many people say, oh, EMR is difficult. Not difficult. When Google cake is used by a coconut vendor on the road, why EMR cannot be used by a qualified technician, doctor? And somewhere, I think in one of the webinars, one of the senior journalists told us in one of the medical seminars that sometimes some doctors are even afraid of entering into EMR because the traceability will there. Maybe in course of time in the insurance companies get into the detail, it will be easy for them to know the procedures and the claims they have made. But I don't think all are like that. Maybe some will be like that. But now the government can give away saying that EMR is required in another 5 years like they did for NABs, then it will work. Then inadequate support and incentives from the government. We have not got incentives, but if you go to Singapore government gives 80% subsidy for automation in any enterprise, be it a factory, hospital, or mall. If you are going to automation, because if they can give subsidy to all these industries, the national productivity will go up. So I think the government should come out with some incentives like Obamacare. In Obamacare, if you have an EMR, the government was giving them some subsidy to the hospitals. And last but not least, regulatory authorities, they still require manual document. That is little sad. Whether it is insurance payment documents, you find that some of the insurance companies send all the documents by courier for payment and things like that. I think that should stop. And even fire safety can automate in the low-code platform. When the fire authorities come, they should not insist on the checklist to be maintained in the manual paper. And I think we should be able to digitize all this. So thank you very much. And I think it was I'm little notorious for talking for long, but definitely the organizers have been very kind to give me good amount of time. 40 minutes is not a small time in a big meeting like this. Thank you very much for the organizers, and I hope I was able to convey something. And I am now on to the organizers, and I'm looking forward to answer some of the questions if there are any. Thank you, ladies and gentlemen.
Thank you so much, sir, for your spectacular and eye-opening
Hello?
speech.
Hello?
I would like to.
Hello?
Yes, sir.
Yes.
Oh, I hope it came out well.
Yes, sir. Yes, sir.
Okay, please go ahead. Yeah, please go ahead.
I would like to call upon Ms. Martina Macy of Second MBA to introduce the next speaker.
Thank you, Karen. Hello, everyone. I'm very happy to introduce the speaker of our next session. Our speaker is the Managing Director of Melon AI. He is a doctor turned entrepreneur who, after completing his MBBS, did MBA in Healthcare Management from Anna University. He has held various management positions in the healthcare industry like Apollo Hospital, Chennai and New Delhi, Global Hospital, TechMed Laboratory, etc. He was instrumental in setting up the startup TechMed Laboratory, which has grown from a 30-employee startup to an 800-employee multinational company. During his tenure as Vice President in TechMed, he was pivotal in acquiring Odisha's government project for hospital lab management. Being a techno-savvy, he has produced many innovative products which have earned him a global recognition. His new venture, Melon AI, is born out of his passion for innovation and technology. Melon AI is started by a group of like-minded doctors who wanted to fill the technological gap in the healthcare industry. His domain knowledge, in combination with his technological acumen, helped to build a product better than a technological expert. He has given various talks about AI in healthcare industry in various national and international forums. And today he is here to talk about us where to start our journey in the new norms needed for automation. So, ladies and gentlemen, please help me in welcoming the assessor for the most coveted Malcolm Baldrige National Quality Award, Dr. Masood Ikram. Over to you, sir.
Thanks, Mercy. Am I audible? And my screen is present over there?
Yes, sir.
Yes, sir.
Okay, good. It is really difficult to make up to Sir when he finishes the topic. We still have a hangover of what he's been telling us so far. I'll see to it that I stand up to somewhere of my level of my knowledge, whatever I have. Hope you have any more information, you can ask me later on this stage. So how do we start here? So we start here saying that the new norm. Yes, pandemic has come. We have spoken enough about what has happened in pandemic. We're running polls to beds to polls, find gas to stations and everything, all possible things we have done. So there's also a time that we stand and we look back. Where do we stand and what we have done and what we have not done and what do we learn out of this and how far have we gone and we have not gone how far into this pandemic situation and pandemic scenario. This was a regular case. We saw that everything was managed at home. The new norms were coming in, new questions were coming in. How do we go about and all this? Telemedicine was been talked about a lot. I myself was a very good advocate of telemedicine. Telemedicine did a very good numbers everywhere. It was wonderful to see a lot of people adapting to the new technology. We were seeing a lot of tools coming in, different applications are coming in that people use, different applications coming in and going out. So that was also wonderful to see. And we've also seen that even elders are taking up technology, joining hands. Doctors are just available over your screen in just 5 to 10 minutes. You don't have to worry about it, standing in the queues and everything. Adaptation was not a big challenge even for older people or younger people, and everybody started adapting to the new norms which was coming in forward and things like that. And we were also seeing a lot of wonderful smart devices, a lot of smart devices from the home. We can monitor this, we can monitor everything. You don't have to worry about this, thing like that. Putting you in this context, my question here is, definitely these are smart things and wonderful things to feel and look forward and all those things. But is it a solution for the entire thing of pandemic, what we're looking in for, or is just a case scenario that we're going in forward? So these kind of smart situations have definitely helped you to improvise your current situation. Is it also solving you the future problems? Or in our management way, I can say, generally we say this root cause analysis, okay? There's a solution and media root cause analysis, and then we find a solution to it. You don't find solution for an issue, you find a solution for the root cause analysis. So all these devices and everything what we are seeing here are definitely a good solution for the current situation, which is pandemic, no doubt about it. But are they a good solution for the future thing which you're talking about? Can we, we're using all the telemedicine, everything tools, whatever we have, Can we able to predict what is going to come in the future? Can we able to predict the assessment of the thing? Can we able to see how far we can go, how quickly we can get things into it, severity of the problems? Are we taking decisions based on the data-driven approach, or we just even the decision of a lockdown? How sure we are when you take decisions like this? So for all the putting to all these kind of things, you need to see that where we had gone wrong, what is the right way to come inside, and the future of something like this happens, where we can stand for. So let's learn, go back and learn what are the challenges we didn't had worked on, and let's work on those kind of things going forward into it. One second, I'll just move on to this is where we were, and then okay. So let's see what are the challenges we have. So we have a situation here. We have this situation here is we have two types of data. One is your financial data, and one is your medical data. Medical data, what we have. What is your financial data? Every patient walks into the hospital. A bill is given to him in every aspect, whether it is for a simple ECG or blood test or to your IP admission, wherever you go about it. Everything has been tracked in the ERP. Then you have something called a medical data. Most of the medical data, though some of the medical data are present inside your ERP, but most of the medical data stays inside the medical records. That's what we see. ERP is enterprise resource management, the software which every hospital has it. So most of the software which has been created is actually to balance out the real scenario, which is the financial data. Every software, when it is ready, it is put into the market. We go in to do an audit and we do all kind of testing to the thing. We do most of the things on the financial data. Okay, if the guy is coming, if the bill, hope the final bill is matching the initial admission days and whatever we have told them what is coming. So data as such has been given importance in the ERP only for the financial data, not on the medical data. Even today, if you need a medical data, if you need a medical information, you hardly go inside ERP. You basically go to the medical records department. Even if you want to know what are the number of deaths we happened in 2018 in a hospital, medical records might not. Medical records can give you much better, but than the ERP. So ERP today is a very primitive way, though a lot of advancements have come, a lot of things have come. But on the medical record perspective, a digital medical record perspective, we have not gone to that kind of an extent what we currently have. I can relate to multiple different ways how ERP could have been much better. I just did 3 different examples here, which can give you the answer that where we stand when it comes to the current ERP system. Prediction. Are we able to predict something coming out of this ERP? Can we able to predict the prognosis of the patient, severity of the patient? Can we able to spread of the particular disease? Can we able to have a clinical approach? Giving you information on the clinical approach? So these are the things a medical record data can give you, but unfortunately we are not able to get it through the current ERP system. And what is it that we have it here? We are also going for research and publication. What we have in research and publication, if you want to do a research or if you want to do a publication, you don't go into ERP. Again, you go back to the medical records and say, I want so and so back data for the respective way or the prospective way. You don't have it in the respective way, collect it in the prospective way. In either of the ways, you need to approach the medical records department. Last thing is, we are talking about pandemic and everything. We're talking about illness and most of the things. When are we moving from illness to wellness? In the current ERP system or the current system, whatever we have, giving us the leverages, helping us to leverage to go into the wellness kind of mode. Can we able to predict what we have or what we don't have? Where do we go? How do we go about on this? See, I totally believe that the current healthcare system has done a lot. It's no doubt that we are a little behind. People also say in some of the places saying that olden days were bad, good days. These are not good days. Everything is polluted. Everything is bad. When everything is so polluted, everything is so bad, everything around you is so bad, why is the life expectancy of a person is increased from 40 years to 70 years? Not too far. In 1960, our life expectancy was somewhere around 40 years. Today, our life expectancy is somewhere around 70 years. A guy today, compared to the guy post-independence, can live 30 years more than what they were living then. We are living in a better world. Please acknowledge that. Let's not get into the way that things are not good around us. There are a lot of things good around us. But are we getting into in a predictive way? Are we getting into the wellness? No, we're still not there yet. We just solve the problem which comes in front of you. Today, you have a diabetic patient, you solve this diabetic problem. Do you have a pandemic? You solve the pandemic problem today. When are we going in from solving a problem to going into and predicting a problem and going forward into it? This is what we are looking into it. When we talk about data, my topic was more about data. When we talk about data, where are the sources of data? What is the data available in most of the places? So one thing is your internal data. When I say internal data, it is anything and everything inside an hospital. Simply just have to walk in your corridor of your hospital. You can see so much of data in everywhere. It's there everywhere. We just don't realize it. We just capture everything what comes comes inside through our ERP. Everything, you walk through your corridor, you can see a scan happening there, you can see a fundoscopy happening there. Even you can said so many things, the drip meter, a lot of things are there. Are we tracking each and every data internally? No, we're tracking more of the financial data, little bit of vitals here and there, and little bit of diagnostic values here and there, not more than that only. External data. So external data is also an external data, lovely kept outside. The insurance data or government data, we don't use them within our system. They're sitting outside. We hardly worry about them. Environmental data, we call it data booster. There's so much of data which will be useful for us in a lot of cases. In between, we were saying something. We were saying that pandemic will not be there when the summer rises up. Somebody said the summer will come, pandemic will go, flu will not be there for longer time. What happened? We were not able to do that. So are we tracking the pollution of the people, pollution of the environment? Are we tracking even the rainfall? No, try to track every information about the environment, because environment, food, and everything relates to the disease perspective and things. And last but is our own outcomes. You would have gone and seen even in Ramachandra Hospital, every year we're doing so many publications. All this publication, all the research are sitting in some papers and somewhere, some corner of the country, some corner of the world, some publication somewhere. Is it been brought back inside this thing within your own ERP system? Okay. For example, there's a study on diabetes, and multiple people have done the same study on diabetes. So all this put together, have we found a single common clinical pathway for our own diabetic patients in a hospital? We're not able to do so. Why? Because today the capacity to build all together is not there. But we do have enough amount of data available each and every places. We're just not able to pull them to a right place, right time. Let's also see the advantages what we have in today's scenario and what we are not leveraging about the situation. Yes, we are talking about cloud computing. Yes, we have enough amount of cloud. We don't have to worry about software installing in a respective laptops or servers or this location. You can keep it in the cloud. It can be accessed to everybody. And how do you access them? Wonderfully through the internet. And today in the internet world, we know how it is. Your cloud, even your primary healthcare system can access to it. And one more big beauty what we have today is the GPU capacity inside the cloud. Those were days when we say my computer is not enough of running speed and processing speed and things like that. You don't have to worry about it. You keep everything on the cloud. So when we have a wonderful thing, we have a wonderful example of everything. Are we leveraging all these things? No, we can. So you have your own data in your hand. You have the technology and the environment around the technology or the resource around the technology are available, but still we are not using the data to the best possible way which we can able to do it going forward. So this is something which we have kind of proposed in a lot of hospital, and we're working with a couple of hospitals. The future of data, how a data of a hospital can be captured. This has also been proposed at a central government level. It has been proposed a couple of hospitals. We are working with the central government. How do you see a data of a hospital, and a futuristic approach is what we're looking in for. First, we propose something like a data lake concept. A data lake concept, data lake, you can understand with the word data lake. So there is something called hospital, there is something called ERP, there's something called wellness center. In a multiple docs available everywhere, there is some emails available everywhere. There's the ERP available everywhere, the small applications available. All this data are sitting in different locations. Just put them everything into a data lake. Then comes your digital biobank. This is the beauty which we have been talking about, and we're building it to some of the beautiful from the hospitals. A digital biobank where what we do, we bring all the data from the lake, put it into a line, and keep it inside digital biobank. Now, for example, in a particular API, a particular wellness center, you have a diabetic data. In insurance, you have a diabetic data. In hospital, you have a diabetic data of the same patient probably. Bring them all, put it into a one particular line. So the same patient, all the different 3 diabetic data in 3 different locations will come to a single point. Biobank will take the data and put it into a standard formats. I will go in detail about digital biobank, what more we can do about it. So once you have a digital biobank in this case, and we go about on this, then what happens? You go into a mastermind. So mastermind is something which we need of the hour. We should look in for the situation where once you have all the data put inside, how do we extract the data? How do we go about all this data about it? And then we have something called care chain technology. Care chain technology is nothing but your blockchain technology. A blockchain technology, we have modified it a bit to the healthcare system. We're calling it care chain technology. And you can see the security manager cover from above and below. Everything is well secured, well architected, well inside the particular security cover. Security cover is more important nowadays because we can keep everything in the cloud server. So this is something, a structure which we have been working with a couple of organizations. I'm sure oil data is a new oil. Accumulating all your data into one particular platform will take you in a different thing. And beauty of this is this entire thing is built in Python as a language. Python language is the core language for the future of AI. So this is going to be a big benefit to a lot of people in a lot of different ways. So what is basically a data lake? Dumping all your resources, and it is like a bidirectionally interface. If it is in live data, or is an old data or a new data, just keep all the data in there and bidirectional interface. You put the data here, you take the data there, you exchange the data however you want it, and you can use it. And we build multiple adaptations to take the information from the data lakes and put it into your biobank. This is the primary source of your data. Second part is your beauty comes to you is about your biobank itself. So the biobank is a beautiful concept which we are building to a couple of hospitals, which has got, though we have got HL7 as a standard norm available, but not application and not ERP, not everybody follows the particular HL7 format. So the moment data comes inside the digital biobank, it automatically forms into a HL7 and DICOM concept. All the particular tool standards what we're using, it comes into it. Standard registry. Unfortunately, we don't have registry in our own systems. Though we call our ERPs are good enough everywhere, but if you have two different hospitals and same ERP is going, the registry is not going to be the same. The patient ID on this hospital and that hospital is going to be the same. The doctor's ID is going to be different from this person. Even the death rate, if you ask from this hospital, is going to be different. So we don't have a standard registry. But once you have a digital biobank, everything comes into a standard registry. Unique ID is still a challenge in India, in spite of we have an Aadhaar card or almost all about the thing. Why? Because they're running multiple different platforms. But you put them under one common platform and you start taking the source out of the one particular platform, you can have a unique ID given to everybody. Here itself we'll have our own auto ICD coding. So we call it like, basically a machine learning based also auto ICD coding. The medical records have got a beautiful book they follow as a Bible. They sit and they code the entire ICD coding. What we have done is we have used machine learning to code all these people. So all the particular records are coming out. So every disease there is automatically ICD coded. We call it something with data booster. Now, yes, you have enough data being captured within the organization, but you also need more data coming in from the geotagging situation, for example, environmental situation, your rainfall situation, almost everything. So we boost more amount of data. You never know. Pandemic is related to somewhere which is outside the external issues. Also, we never realized the wave 2 has come in. The wave 2, when the peak came, the pandemic was also on the peak. They also said when the flood came in for Chennai and the flood came in for Gujarat and Maharashtra, it washed away the entire thing. This was one of the theories coming up. How do we relate all those things? Once you have a data booster, when you put all the data, every information around it, around a patient or a hospital or a geography or society, put everything into it. Convert all digital formats. Unfortunately, our X-rays are never converted into an ERP. Our even pathological smears are not converted into an ERP. Our scan reports or fundoscopy reports, nothing is converted into an ERP. Convert most of them. We have tools today, wonderful tools that we can easily convert them to ERP. Put everything inside the digital biobank now. And of course, when everything is digital, paperless is one of your biggest advantage. Now here comes the beauty. I've given few examples of mastermind, just few examples of mastermind. What are the wonders a futuristic data structure can give it to you? Okay, we can have an AI platform where AI, machine learning, and cognitive and chatbots can be created overnight. We just have to think over it, and we can create a chatbot or a machine learning over it. Auto claim and auto reject. A lot of people have been talking about auto claim and auto reject. Why are we processing of the insurance takes so much of time? Once you have data inside, auto claiming and auto rejecting becomes much more easier. Then the thing called deep analysis. When you have the data, you have secondary data, then you have tertiary data. Something comes out of the primary data. Use the primary and secondary data to make a tertiary data. Go deep analytics and see what more information we can get. So wellness and illness has also been put up here. These are the kind of mastermind things we can give. Now, once I give you the capacity, the data is there with you. You can think wild. Today, there's an inhibition of me thinking wild also. When I want to think something beyond something, I'm going to stop at no the data LEA. We don't have that. We might not be thinking everything is right in format. But I'm going to give you that. You just think over it, doctor. You just think over it, madam. We will have it done for you. This is the power of the mastermind. You just think you're going to have it, and everything can be built in because everything is built in. And Python is a beautiful language for all the AI, and everything comes inside. This is something just I wanted to give you about this thing. This feature about catch-in technology. I'm running a little late on time, so I just don't want to touch more of the thing. This is basically a blockchain technology. Do study blockchain technology is available in everywhere. We think we relate blockchain technology directly to cryptocurrencies. No, blockchain is a technology by itself. No, it is a beautiful technology where it cannot be corrupted. The most secure way, nobody can even come and hack it. You can even have online access and validation. For example, I need to go access, it knows who has come and access to it. And there are other advantages. So learn more about CAT-in, blockchain technology. We call it CAT-in technology. We're giving it to a couple of hospitals in this case. My beautiful topic always stands when you have so much of data available, and AI is the future. And we think that AI is there, AI is not there. But yes, AI is there. Look at this particular slide. Look at this day. Look at the number of people who have come inside AI so far. There's so much of AI available. There are so many companies are working on AI. Most of them are working into the data. But unfortunately, not everybody is. They're not able to work. All these companies not able to work in a retrospective manner. We all are working on a prospective manner. That means start collecting data from today and take it forward. So they have divided them into telehealth, patient-facing, research level, personal level, genetic. We have different classification, and people have been working a lot. In future generation, you need to know what is AI, how an AI can build tools for you, how can you take it forward. This is the future you're going to see. This is one of my favorite topic, and I just touch upon a few things to give you an idea. You have your data, wonderful. What are you going to do next? Do you think you can do something out of it? Just have a little bit of small idea. What are the tools available in the industry of artificial intelligence which can help you build something out of it? The first one, of course, is the most prominent one is your computer vision. So basically, what is the computer vision? You train a computer to know what is in front of the picture. For example, I take my cat's photo and I train my cat's photo for 100 different times, and I show my cat's photo again, it can able to identify this is my particular cat. It's called facial recognition. So we just see facial recognition. Computer vision is one aspect about it. We can also see reading about CT scan. We can be reading about an X-ray. We can reading about anything. So give any particular vision, give anything to the computer vision, it reads the normal and identifies the abnormal. We have done a lot of work on facial recognition. I will not put all of our works, whatever we have done in AI today, but this is what we actually do it on a daily basis. But I'm not sitting like a sales guy and giving you all these things. So we'll go forward on it. Machine learning. So what is a machine learning? The moment we use the word machine learning, we imagine there's something called machines available everywhere that does kind of an automatic job about it. No, machine learning is basically an application. You take an Excel sheet, okay, Excel sheet is a huge amount of data. You give that Excel sheet to the machine learning. Machine learning learns the entire data which is there in that particular Excel sheet. Now you ask question to the particular Excel sheet saying that you have machine learning. Now that you have learned the entire Excel sheet, now tell me what is the value of this particular patient. Sugar value of particular patient, you can able to tell you. Now I can ask him, do you know that you know the 3 value of this particular patient of the glucose? Can you predict the 3rd value of the patient? It can give you a predicted amount. It might be right, it might not be wrong. The accuracy will be different. But now that the machine has learned, you can ask him the predictive questions. What can, what, how much, all those things machine learning can able to give you. A chatbot, a beautiful example, we use it on your day-to-day life, your Alexa, your Google Home, your chatbot. We have built so many chatbots for OT management and patients management. A lot of managements we do. Voice-based chatbots. A lot of chatbots have been coming inside. A PoseNet. PoseNet is a beautiful technology. When you walk in front of a particular camera, it points takes all the points of your body. It assesses the way you walk. So the number of steps you take on a computer. On camera, it captures all your technology. We have built something. We have built a technology to a particular hospital where it captures the yoga. It's been very common nowadays that we turn on in YouTube, and in front of the YouTube we go and do this yoga and use this Zumba and whatever the things. Here what you do is you turn on an application, turn on the camera on the application. Now open the Zumba. Now you start working on the application. Now what will happen is the camera is on, the personal technology will capture the entire activity what you're doing in an RPM level. Wish I could show all these things to you, but unfortunately we don't have time. On an RPM level, it will tell you to what level you guys have worked. You have not worked. You were sitting idle. You know you are actually working. You go back to your doctor. Doctor will tell you, no, boss, you have not worked the last week. You worked last year or whatever possible. Deep learning is there. So when you have a computer vision and machine learning, this deep learning goes little much deeper and learns and gives you more and more information what is available on them. A cognitive learning is a very advanced way of artificial intelligence, where all the learnings of the current one, you take computer vision, machine learning, chatbot, all put together, ask him to learn further using all the tools. It will give you an outcome of all this particular thing. I think something is like this, something like available there or not there. That is called your cognitive technology going forward. It's one of my favorite topic. I never miss this topic whenever I go forward. Publication versus application. So what is the publication? So you as a doctor or you as a healthcare manager, you have done some publications everywhere. All the publications you do, how do you do a publication? You go, you use the data, you analyze the data, you take an inference of the data and do a publication of the particular data. Now this data is been published on a paper which is kept some corner of the world. Good enough, not bad. Somebody can read to use it like that. My argument here is, when you already worked on the data, when some inference is coming out, let the machine learning learn this particular data, what you're seeing, and convert this particular application to a machine learning application. And it is like an application that stays in the cloud. Anybody can use it. I'll give you one example, a beautiful example, which we have been building to one particular thing. So there is one particular hospital in Chennai. I don't want to name them. Particular hospital in Chennai, known for gynec. That particular doctor is known only for doing normal labors, not more of surgical labors, cesarean labors, more of normal labors. So the moment a patient comes, he tries to avoid cesarean. He does more of normal labors. So what we did, we went to him. We took the entire data of him. Sir, give us your data. I'll build an application of it. Here's a lot of publication. Yes, we took all the data. We made a machine learning and told the machine learning to predict this patient tomorrow will go in for surgery or can go in for normal labor. Now I'm a new doctor coming to the particular ground. Me, instead of thinking my own self, this will go in for surgery or not, I use this application. I say, so and so patient has come, so and so patient, so much gravida, vagara, all that thing you put inside, and based on the previous data, இந்த மாதிரி patient இதுக்கு முன்னாடி வந்திருந்துச்சுன்னா நம்ம வந்து surgery பண்ணியிருந்தோமா இல்ல we had postponed it for a labor. The system says 70% the chances that it might go in for labor. Then I will still wait. Let's not go in for surgery. Let's use for some time and go in for labor. So it's a simple example how we have been using. So we can build enough amount of applications like this. Think about the people sitting in the tier 2, tier 3 cities when they don't have access to the tertiary care. These kind of applications is going to help a lot of people in a lot of different ways. Just spread the word to the people instead of publication. Let's use more of application. I don't have time. I'll go quickly forward onto this. So AI adoption is there almost in every country. These are the top 5 countries where adoption is there. Though this data was published by Deloitte in 2018, this now is not changed much since the pandemic and everything going forward. So we can see the top countries here. Unfortunately, India is not there in this country. And look at the comparison of China. He was just 21%, and he is coping up to come up to 55%. So AI is the technology. AI is the future. People understand it. A lot of countries are moving forward it. The irony here is the bigger companies like Google or Microsoft. Our CEOs are there. Our people are there. Our people are working everywhere. Our people are making this company much stronger and much more valuable. Unfortunately, when it comes to our own countries, our name is not there here. Please have your sensitivity towards the data, have sensitivity towards the AI. Let's invest more into AI. This is a future. Let's not be behind. We were behind in our in a lot of other industries, like when the revolutions were changing. AI is also one of the revolution. If we miss this revolution, we might be going down again to a developing country only. It stands for us to become a developed country in the future. Now, this is a very simple approach. I will take very quick approach onto this. We call it a 4D approach. Now that we have told you what are the data, where the challenges are, how to capture the data, and we've also told you what are the tools available, how do you use the data particular thing. Now, how do you go about onto it? And how do you go about onto it? So we call it a 4D process where we dream, we define, we discover, and then we deploy. So you need, on the left-hand side, you can see you need data, you need technology, you need right amount of people, and the organization definitely too. You already have a beautiful organization, Ramachandra as nothing, and data also have it abundant with you. Now that we have got an MOU with Ramachandra, I'm looking forward the students who are listening to this, other people listening to this, can use this platform to come to us, because the data point is there. You can see the technology part. We will help them bridge the technology part in between. You have good amount of motivated people. So let's build something out of this and take it forward into it. So what generally happens, you envision a dream, you need to look into the data, whatever you have, you need to have a motivated people. Once you have all these things, then you go and define, analyze and explore a problem. Let's explore a problem. It's possible, not possible. Do we have the data for it? Yes, we have the data for it. If we think everything is possible, then we get into a discovery mode. A discovery mode is something, we try to do take a small amount of data from whatever data we currently have. We put them into a discovery sprint, and we see it is possible and outcome or not come. Good thing about AI and machine learning, thing about it, you don't need too much of hardware tools or anything. You just need a small amount of data application, what you have, put the data and see it's possible or not. Once you get a motivated advantage, just looks like things are going in, then you go in for a deployment and then you further development into it. It's easy to do. Looking forward for people who are watching this, who want to develop something on AI with the data, whatever you have, part of the team, because the MOU has already been signed with Ramachandra Institute. Watch out for UKD is already spelled out on regulations. What is the kind of regulations we already have? There are regulations throughout the world which is called GDPR, which is like General Data Protection mechanism, which is there in UK and which is very strict in UK. And the fine for basic simple fine for that is 20 million euros or 4% of your global income. Even Google had to pay this in a couple of countries, because they were not able to keep that in the norms. It is coming to India as well. So GDPR, we're calling it the name of Disha, is coming to India as well. We will take it forward onto it. And there's something called Open AI and there's something called Closed AI. So generally we prefer to build something in Open AI. When you say Open AI, we can able to open the particular application, see the script, how you have been written. This will prevent you from unethical use of AI. So everything is Open AI. We can go, we can modify, we can change. This will also give you an leverage advantage to the patient, to the people, to the doctors. We say AI will take over the humanity. No, I also believe that now that I've worked in AI for like 2.5 years now, I'm telling you, no AI can take over human. This is not possible. But yes, AI can help augment doctor's capacity. That is possible. A simple of your calculator, when the calculator was there, we felt the calculator is of no use. But calculator saves your time. Calculator helps you do bigger calculations in seconds. You don't have to worry about. Likewise, the computation power of AI and everything will help you augment only. So you can spend more time with the patient with a more clinical approach. That's what Open AI can help you do. Ethical clearance, yes, it is very important to take your idea, put it in an ethical committee, clear it through an ethical committee. Nobody can object you in henceforth after that. Keep it like that. And definitely you need to have a wonderful agreement between the third party and thing when you're going to share the data, something like that. This is a small example. I just have last 1 minute. I not take more than that. You can see this is what we have built, and you must have seen in Alexa. So telemedicine have a challenge that everybody were approaching, every doctor available on the market. So we converted the AI, we converted the Alexa into our own tool, and if you can able to hear it, you can understand. So I was done with that. That was my last slide, anyways, bringing it forward. I'll leave it to gentlemen everywhere here. I can put that in a particular YouTube link and then put it across the thing here.
Thank you, sir. That was such an informative session. Moving on to our next session.
At the end of the session, sir.
Sorry?
We can take up the question at the end of the first session.
Sure enough, yes.
Or during the panel discussion.
So moving on to our next session, it's a great pleasure for me to introduce our next speaker, who is going to talk to us about the P4 medicine, which is a very interesting topic. Our speaker works as a team head at Accenture. He graduated from Government College of Pharmacy, Bangalore, and did his postgraduate diploma in pharmaceutical sales and marketing. He began his career in healthcare journey with 6 years in pharma marketing, 2 years as a hospital pharmacist. Working at Accenture, he has about 5 years of experience in clinical data validation in pharmaceutical research and development and 10+ years of experience in healthcare IT. He is specialized and certified in US healthcare. With 24 years of experience in healthcare, he has worked across various EMRs and multiple modules in testing, maintenance, and support projects. So, ladies and gentlemen, please help me in welcoming a proficient man of gap with analysis in healthcare, Mr. Ashwin. Over to you, sir.
Thank you very much, Martina. So today I would be speaking about on touching on a new principle which has been in light in the medical industry. So usually what happens is nowadays whenever disease it occurs in a patient, we wait for it to progress, get the symptoms, then we take up the diagnosis and the suitable treatment is provided. So presently the healthcare is trending from reactive to proactive approach. So what happens is, as already Dr. Masood has told, like there is a lot of challenges, and we need to take a drive towards the predictive nature of approaches. So that's what P4 comes in, and it's already in place, and it's still having a lot of area to be developed, and implementation should be accepted across the globe. Now, if you take what is P4 medicine, it is actually individualized medical care that involves your participation, predicts and prevents a disease to strengthen your health, ultimately creating a personalized life wellness plan for an individual. Now, for example, as everyone agree, today whenever there is a simple problem of a fever, for 4 patients with the same age, gender, and type of environment they live, if a doctor recommends a paracetamol, maybe it will not be effective as equally as same for all the 4 people. So it differs between patient to patient. So that's how they want to personalize the treatment for a particular individual. So P4 medicine is actually based on some 3 different principles in the approaches. There is something called as systems biology, where the information technologies enhance wellness rather than just to treat a disease. This actually is a combination of the 4 cadres, like the predictive, preventive, personalized, and participatory medicine. To address this, it should be a consumer-driven health, and there should be a lot of implementation of IT, social network gathering, and social networks to be integrated to provide a better results, so that the current medication will have to be evolved from a reactive to a proactive system. Now, P4 medicine actually it's an emerging which contains of extensive data collected from number of parameters related to the ill health through an individual's though through the diagnostic test, health apps, other tools like the IoT, as already it's mentioned, like the smart devices what the patients will be using. So the major thing to understand the risk factors and counteract them, there will be one more concept which will be called as a system medicine, which will be another approach for the being making the successful of P4 medicines. Now, if you take the clinical evaluation, there will be a lot of parameters or risk factors which will be surrounding the patient health, which has to be integrated, and based on that, the computing decisions have to be taken by the medical professionals to provide the correct treatments. So it also includes conventional medical histories, clinical tests, and the results of the tools of the system medicine. Now, if you take a general aspect as a patient, as a personal, there will be a lot of factors which will help in creating the particular condition, which may be the environmental factors. Maybe you might be living in a very extreme cold areas, or you might be in a tropical countries or something like that, and this genetic markup, and because it is carried out with the genes and its heredity and the culture tradition what they come across, so that will depict the personality. And there will be a lot of key biomarkers which will be available in identification and provide a suitable treatment for a particular disease, and maybe his treatment history, what types of conditions he had gone through and what medications he would have taken, and his behavioral preferences. Now, the main objective is for the P4 medicine is to quantify scientific wellness and demystify the disease. The main source for generating all this healthcare data from medical care providers, public and private payers, ancillary service providers from the pharmacy to the laboratory. Now, it means that all the data collected should be stored somewhere in the database, and that data should be used with lot of stringent rules and regulations so that it should be confidential and integrity should be maintained with respect to that patient data. Now, predictive and preventive means it's our bodies cannot be subdivided into individual components, but rather genes, proteins, cells, and organs react with each other and environment in a complex way that can vary over time. So if you go for personalized, we use the molecular and diagnostic technologies to look at the genetic profile and biomarkers of diseases, opening a new pathways to match each patient with the treatment regimen that may give them the best results. The major thing is that the patient has to be participative with respect to the protocols, and he should follow all the instructions given uh, so that the medical practitioners, policymakers, industry researchers can give them a better care and make their health a well-being. Now, genomics is a study of all the person's genes, including interactions of those genes with each other and makes with the person's environment. To do this, you need to know the unique properties of a patient. So genomics is the thing which makes it possible. There is a huge focus on genomics in personalized medicine. Now, for example, if you take a person known that there is a strong possibility of a patient becoming diabetic or suffering from hypertension or receiving a cancer diagnosis, how would you change the treatment? It would allow the doctors to treat the illness in the way that best suits the specific patient. Now, the Human Genome Project was devised and by the research effort in combination with the US Genome Project, which took about 13 years. And the project was launched in year 1990 and completed on 14th April 2003. And it have a genetic code of 20 to 25,000 genes in the human genome. Lot of work in this front was done by the government uh, using two departments, that the Department of Energy and National Institutes of Health, the US Genome Project. The main goals of that particular project was to identify all the genes in the human DNA, to develop a genetic linkage map of the human genome, to obtain a physical map of human genome, to develop the technology for the management of human genome information, to know the functions of the genes, determine the sequence of the 3 billion chemical base pairs that make the human DNA, and store this information in public databases, develop tools for data analytics, and transfer related technologies to the private sector. What is systems biology? Now, if you take systems biology, it is an approach in biomedical research to understanding the larger picture, be it in a level of an organism or a tissue or a cell, by putting its pieces together with the help of computational and mathematical analysis and modeling of complex biological systems. It involves taking the pieces apart. One of the aims of system biology is to model and discover emergent properties of cells, tissues, and organisms functioning as a system whose theoretical description will be only possible using the techniques of system biology. These typically involve metabolic networks of cell signaling, and human mind cannot keep a track of so many processes in parallel. So how can we calculate the effects of the cellular functions? The very most viable options is to construct highly detailed computer models that facilitate the visualization and statistics to see the trends. The mathematical modeling to precisely calculate interactions of components will predict the system behavior. Now, every day, modern medicine improves, but only 50% of the medical cases are chosen treatment which does not benefit the individual patient, reason being fragmented approach to the patient system. Now, if you take clinical guidelines are based on a non-existent average patient that are very different from the patient in the consulting room. Now, for patients with multiple illness, treatment guidelines might be contradictory. On the top of that, there still much we don't understand the way the disease starts to develop. So the networking, we have to integrate the model of data, which is can enormously increase the signal to the noise. Now, systems medicine, actually, every patient is unique, like a barcode. by breaking it into own individual components, such as the proteins, genes, tissue composition, visualization by images and scans. For each of these components, clinicians already measure and gather a huge amount of data. So clinicians will have to work with a multidisciplinary team, modelers, data management specialists to combine the data into a dynamic model. Then the model should be fine-tuned as an ongoing cycle of testing and feeding additional data into it. Eventually, these models will evolve into working simulation of the patient system on the subpopulation level, as well as treatment outcomes in different scenarios. So this will help in tracking the disease pathways of various levels, the human body to organ and to organ subcellular levels, achieve detailed understanding of the human physiology, based on the human data and human model instead of animal data models. Because usually if you see like all the drug development would have happened based on the preclinical studies, which happens on the animal data, and then based on the safety, then it would be coming to the human trials. So if the system medicine is incorporated or implemented, we can directly, based on human data, we can analyze, and we can get the treatment methodologies at the faster rate. Now, delivering personalized treatment for patients, open path, and personalized medicine. Life scientists, modelers, and clinicians need to extend and engage in the multidisciplinary collaborations to develop models as well as protocols for collecting and managing the data. Now, system medicine is about to change all that, a new approach in healthcare that draws from principles of systems biology. Now, big data will transform the approaches in healthcare that have long defined the industry. No longer we will pull the data of the individuals to predict what happens at the population level. Instead, population data will be so comprehensive that will accurately predict what happens to an individual patient. The global big data analytics in healthcare market, especially in US, it was expected to be $16.87 billion in 2017, and it's projected to reach $68 billion by 2025, with the cumulative annual growth rate of 19.1% from 2018 to 2025. Now, there are major key players which are operating in the big data analytics in the healthcare market, includes Allscripts, Cerner, Dell EMC, Epic Systems, GE Healthcare, HPE, International Business Machines Corporation, Microsoft Optum, and Oracle Corporation. So large amount of data that being is generated, it is to be consolidated and analyzed continuously in the healthcare space. Healthcare data analytics solution will draw specific statistics from the data to research new advancements, simplify the processes, reduce costs, and make healthcare more affordable and efficient. There are 3 V's which characterize the big data, which also help apply. The volume. The healthcare industry generates massive volumes of data through endless sources ranging from an electronic health record to the sensor embedded variables, which are already even discussed in the previous talks. So there are a lot of IoT things which generate data with respect to a particular individual. A patient's electronic health record will form an hub of the patient care. Instead of manually entering the data into medical devices, will automatically generate data into the EHR, which will add convenience and reliability. So data can also provide big lifestyle devices like monitoring exercises, sleep cycles, and heart rate. This will give a physicians a more cohesive picture of the overall patient's health care. So there are even variety of data which has been accumulated from the healthcare, maybe depending on the medicines or types of health parameters, drug proportions, behavioral data, and others. And velocity is the most challenging thing today in the data analytics in the healthcare sector, because a lot of data which is generated and being pumped into the EHRs is constantly generated in the real time, which is leading to a data generation at an unprecedented velocity. Now, big data analytics along with IoT, uh, along with the Internet of Things, is revolutionizing the way one can track various user statistics and vitals on real time, apart from the basic variables that can detect the patient's sleep, heart rate, exercise, distant walk, etc. There are many new medical innovations that can monitor the patient's blood pressure, pulse oximeters, glucose monitors, and more. The continuous monitoring of the body vitals along with the sensor data collection will allow healthcare organizations to keep people out of the hospital, since they can identify potential health issues that can provide care before the situation goes worse. Now, reducing cost, like even big data can great way to save the cost for the hospital, either by over or underbooking staff members. Predictive analysis can help to resolve this issue, predicting the admission rates and help the staff allocation. Based on the seasonal changes, we can expect the spurts in the inpatient patient flow. Now, example is COVID, because it's unpredictable. We can expect the inflow of a patients to a very larger rate, so that the hospitals can design and plan the investments and invest to the maximum with get more returns with the less investments. So the insurance industry also can save money by backing wearables and health trackers to ensure the patients which do not spend time in the hospital. So it can also reduce the wait times of the patients, since the hospital will have adequate staff and beds available as per the analysis at all time. Now, predictive analysis can also help in cut costs and reducing the hospital readmissions. Now, according to recent reports, 47% of the healthcare organizations are using predictive analysis, and as noted, over 57% of the healthcare costs believe that predictive analysis will save organizations 25% or more in annual costs for the next 5 years. Assisting high-risk patients, if all the hospital records are digitized, it will be a perfect data that can be accessed to understand the pattern of many patients. It can identify the patients approaching the hospital repeatedly and identify their chronic issues. Now, such understandings will definitely help in giving such patients a better care and provide an insight into corrective measures to reduce their frequent visits. It is a great way to keep a list and check on high risk patients and offer them a customized care. Now, focus on value-based care by removing the responsibilities of error. As you all know, medical error today is one of the leading causes of death, and the core issue of every healthcare is focusing on. Healthcare data analytics will definitely help in and combat against the human error occurring in the patient care. It may be a wrong medication administered by the pharma professionals, or it may be wrong administration by the nursing professionals, or there may be a variation in the decision making of the doctors. So definitely healthcare data analytics like the clinical data decision systems will help them to analyze and reduce the risk of human errors. The Centers for Medicare and Medicaid in US services prevented more than 210.7 million in healthcare fraud is one of the years using predictive analysis. Now, advancement in the healthcare sector, apart from the current scenario, big data can be a great benefit for advancement in science and technology. For healthcare, artificial intelligence such as IBM's Watson's can be used to surf through numerous data within seconds to find the solutions for various diseases. Such advancements is already in progress and will continue to grow with the amount of research collected by big data. It will only be able to provide accurate solutions, but also offer customized solutions for unique problems. The availability of predictive analysis will assist the patients traveling to particular geographical location by studying similar patients in that area. Now, the big data increases the ability to healthcare sectors by providing predicting epidemics, cure diseases, improve quality of life, increases preventable care, begin early preventive care, and spot warnings of the signs sooner. There are a lot of critical AI which is used in medicine, especially in the field of diagnosing skin cancer, automation of radiology, Alzheimer's and coronary heart disease detection, breast cancer detection, colon cancer detection, diagnosing heart diseases, diagnosing and categorizing blood infections, typhoid fever detection, and tumor detection. The major of the big data databases that related to patient care are the electronic health records, medical device data, insurance claim data, health information exchanges, patient portals, genetic databases, public records, social media, and the research data. So these are the places where we can expect a lot of data to be generated on the patients, and which can be subjected to a lot of analytical tools used like as automation tools, machine learning tools, and cloud database managements to be implemented, so that it will help in providing a better care for the patients. So from this, I would be coming to end of my session. I would be glad to take up if any questions are available.
Yes, sir. We'll take questions at the end, sir, during panel
Okay, fine.
discussion.
Okay, fine, right, yeah.
Now I would like to call upon Dr. Julian Dileepan of First MBA to introduce the next speaker of the session.
Good morning, everyone. Today's event is a very meaningful program where we can share experiences and knowledge about leveraging technologies in transforming new normal healthcare system. We, the Faculty of Management Sciences, Srihar, profoundly delighted to take an opportunity to welcome our speaker, Mr. Jaykant S. Kesan, CEO and Managing Director of ZMed's Healthcare Technologies. Welcome, sir. ZMed provides advanced solution for critical care, medical IoT-based automation, and clinical intelligence solution. Mr. Jaykant graduated with Bachelor's in Engineering and Electronic Communication from Madras University, pursued his Master of Science from the University of Texas, and Master of Public Administration from Harvard University. He is known to be a very passionate about his career. Mr. Jaykant is currently working as a CEO and Managing Director of ZMed Healthcare Solution. He has been working there since 2015 with more than 15 years of global engineering and management experience. He has worked with many companies such as IoT Devices, Banks Group of Limited, National Knowledge Commission, Government of India. Digital transformation in healthcare has been affected all levels of care. Adopting the technology is a very beneficial in healthcare. Patient safety and delivery of care has certainly improved with advancement in technologies. These resources have been made readily available at all the levels. Smart ICU designs. Smart ICU design contemplates the ability of the system to communicate, facilitate, and recreate all the elements of the deliveries of medical care in ICU. The concepts such as action reaction, real-time data collection, and integration of information as well as predictive algorithms. The future of medical care, including ICU care, is personalized, centered in the singularity of the human being. Ladies and gentlemen, let's welcome Mr. Jaykant S. Kesan, who would love to share his knowledge on digital ICU with their importance and application in the modern healthcare to us. Welcome, sir.
Thank you, Julian, and thank you, everyone. Thank you, Uma Madam, for this, and thank you for all the co-presenters and panelists. I'm very glad that I could present this topic on digital ICU, digital and smart ICU. So smart and digital ICU, the basic idea is about achieving better clinical and economic outcomes at scale. So there are two objectives here. One is the economic objective and another is the clinical objective. Economic objective is very important because particularly for a country like India, or for that matter anywhere in the world, the number of expert physicians are less. However, the demand for more and better care is growing. So definitely we need to leverage technology. And the second objective is how we can provide better care and achieve better clinical outcomes, and that too at a large level or a large scale, because as we move forward, the things are getting more complex. Providing advanced clinical care is a challenge. So how to leverage data sciences, how to provide real-time monitoring, how we can use technology to automatically compute multiple things, how to provide advanced clinical decision support systems. All these things encompasses smart and digital ICU. Now, before I actually enter into this particular topic, I would also like to clear or emphasize on one more point here. When I say ICU, I don't necessarily mean, or we should think beyond the ICU. So what are the other care units? Apart from ICU, particularly in a hospital, operation theater is more critical. Emergency room is very, very critical. Ambulance system is also very critical. So we are using the word smart and digital ICU ICU as a placeholder for all these critical units. So how we can improve or digitize and then bring smartness into all these care units would be the topic of this presentation. So, as I said, what are the major objectives here? From a technology standpoint, the objectives are comprehensive clinical data integration and provide anytime, anywhere access to all the clinical data so that physicians, doctors can make clinical decisions from anywhere. So that is one major objective. Second objective is to provide automated workflows. Second objective is to provide automated workflows for different units, ICUs, operation theaters, emergency wards. So how to digitize that. And the third thing is provide a very comprehensive electronic medical record coupled with multiple clinical decision support tools. So these are the main objectives of a smart and digital ICU. So if that is the objective, what is the problem right now that is predominant in the industry, particularly in almost all hospitals in India, is that there is a complete absence of real-time monitoring. So real-time monitoring and data-driven intelligence, specifically in an ICU. So this leads to multiple inefficiencies that impedes delivery of clinical care at scale. So when we talk about real-time monitoring, if you visit any ICU or other things, some kind of monitoring is done. At the very best, there may be a nursing station where data is shown, but that is not real-time monitoring because the data is not continuously fetched or stored anywhere for doctors outside the ICU to have a live view and then access clinical records. So what are the current inefficiencies in most of the ICUs is that first thing is patients' clinical and vital data are not automated. They are maintained on sheets of paper. Specifically within an ICU, most of the hospitals maintain something called an ICU paper chart. So in a very time-consuming manner, nurses actually manually copy the data from the patient monitors, ventilators, and other medical devices. So this is very error-prone. The primary duty of the nurse is to provide clinical care, administer care, but almost 60 to 70% of their time is literally wasted in manually copying the data from medical devices such as patient monitor and ventilator. And the second problem is, since the clinical data is within the ICU, there is no scope for any doctor to do a remote monitoring, or they have to actually come to the ICU to make any clinical decision. And there is also absolute absence of data integration from other sources. So that's the main problem. You are not able to provide clinical care or make clinical decision from anywhere outside the ICU. So that becomes a major problem. And large hospitals, corporate hospitals, or any other hospitals, since they haven't leveraged technology, it is very difficult for them to expand and provide services at multiple locations because number of expert physicians are limited. Since technology is not leveraged, they are not able to expand. So a smart digital ICU fundamentally solves all these problems. First thing a smart ICU should do or have to do is provide automatic data integration. So in our case, in our company, we have this product called ZMed, where we leverage IoT, LAN, and Wi-Fi technologies to directly integrate data from multiple medical devices, including patient monitors and ventilators. And all these data are fetched real time. So now when we talk about medical data or data integration, data is not only from these medical devices. There are other sources of clinical data, primary among them are laboratory research data and also radiology imaging data. And also there will be significant amount of non-clinical data from in the hospital information system. So a smart digital ICU should be able to integrate data from all these sources real time. And the second thing that a smart digital ICU aims to do is to provide a intelligent workflow application and an EMR. So nowadays, most of these applications are provided as an enterprise grade web browser based application, which could be on the cloud or could be on premises as well. And this browser application doubles up as an EMR and doubles up as a clinical decision support tool. So your ICU or your care unit, either the operation theater or the emergency unit, completely becomes paperless and it is fully digitized. And the third primary objective is to provide automation. So what are the different areas of automation that a smart ICU could provide apart from live monitoring? So live monitoring and EMR is one thing, but apart from that, from the clinical side, automated computer scores or automatically computed clinical scores. So, but particularly for a patient in an ICU or in any clinical unit, this clinical scores become very important. And if you're managing 50 or 100 plus patients in an ICU, it is very important to figure out rather automatically who among them are more serious and who among them are very critical. So these things can be highly automated once the data, the clinical data is available digitally to a computer. So exponential improvement in clinical care happens because of these kind of automation. And apart from that, automatic report generation, automatic alerts on various clinical events can be sent to the doctors and other care providers. Another very important progress that a lot of companies are doing, or the buzzword right now, is how we can leverage data sciences and artificial intelligence in providing better clinical care. The primary among those is how to actually predict certain clinical event well in advance so that doctors can prepare themselves and treat the patient. So some of those things are sepsis and mortality prediction. So including our company, very few other companies have also come up with algorithms, artificial intelligence based algorithms that to predict sepsis 12 to 18 hours before onset. For example, we can predict sepsis 12 to 18 hours before onset with an accuracy of more than 90 to 95%. Similarly, AI can be used to leverage radiology, automatically estimating the severity of pulmonary disorders, automatically estimating other disorders based on radiology images, either it be a simple chest X-ray or CT scans. So all these three and more components combine together to form a comprehensive digital ICU platform, or we can say a digital ICU ecosystem. So a typical deployment of a smart ICU would be basically centered around a server application, and this server application could be either on the cloud or on the hospital premises. And the server application communicates to all the medical devices through a very specific clinical network. So this clinical network is formed with a combination of IoT and Wi-Fi technologies, which would automatically connect to almost all standard medical devices within the hospital, both bedside and non-bedside medical devices. And data is fetched real time by the server from these multiple medical devices. And individual users, wherever they are, can remotely log in into the server and then access the application to uh, access the application to see real-time data and also to see clinical data of the patient from anywhere in the world. So particularly in our case of ZMed, we have this web application, and we also have iOS and Android mobile application. And we also provide a command and control center. So all these things becomes the part of the technical side of, or the rather the software and then the networking side of the digital ICU, which is primarily the backbone of the entire technology. So the same thing, what you have done on a single bed can be integrated to multiple device and multiple ICU. So a single central application can manage multiple hospitals. So multiple hospital centers from different units can be easily be integrated, and doctors and care providers can access the application or access the smart ICU from anywhere and make clinical decision. So imagine this, an expert doctor need not actually fly into the ICU or drive a long way into the ICU. At a moment notice, an expert doctor from anywhere will be able to not just audio visually communicate and see the patient, but also have access to all vital information regarding that particular patient, and then the entire history of the patient will be accessible to him anywhere, so that a right clinical decision can be made. So that is the power of digital ICU. So when it comes to the technology side, the components are multiple servers are put in for redundancy purposes. You have a database layer, you have the device interface layer, and you have the web application layer. So all these things mostly forms on the technology side, and this level of higher level of redundancy and other things are put so that there is zero downtime in the entire application. So as I said, so the smart digital ICU is not just only for the ICU per se, but also for the emergency unit, ER, operation room, high dependency units, and wards and ambulance. So basically, the entire inpatient unit, the clinical services, the clinical data, and then the clinical care of the patients in all the inpatient units can be fully digitized and automated. So just to reiterate some of the top features of Smart ICU is to provide a 360-degree full spectrum of data integration, medical devices, laboratory, and radiology, comprehensive data-driven intelligent workflow, enterprise-grade EMR, anywhere, any device, anytime access to care providers, advanced alerts and reports. Of course, when it comes to medical data, digital security, data security and privacy becomes very important, and that is also taken care. And another very important thing is advanced data analytics, automated computation of clinical scores, AI-based predictive models for sepsis, length of stay estimation, and prediction of ICU discharge. Say, for example, from a clinical standpoint and from a billing and financial standpoint, it becomes very important to estimate rather on a continuous basis how long this particular patient will stay in the ICU. So length of stay estimation can be automated, and also whether this patient can be discharged from an ICU. So that is also a very major decision, like to avoid readmission, because readmission of a patient into an ICU is a big thing. I mean, the quality standard automatically comes down. The clinical well-being of the patient is highly compromised. So whether to discharge a patient from an ICU has to be as accurate as possible and has to be more definitive. So artificial intelligence can be leveraged to look at past history of the patient, recent history of the clinical history of the patient, and then make a decision whether the patient can be discharged or not. And then the final one, probably the most important one, is providing a way for audio video communication and a central monitoring, so that care providers can from anywhere can not only engage in an audio video communication with the patient, but also with other care providers in the hospital. So when it comes to the EMR, the electronic medical record, multiple modules are provided, and the smart ICU also encompasses this EMR, where a complete comprehensive record, clinical record of the patients are kept. So another important topic when you talk about ICU, you just can't stop or you should also discuss about tele ICU. So a lot of people talk about tele ICU from a perspective of telemedicine or from a perspective of audio video communication. So here I would like to emphasize one major point here. Just by having a audio video communication with the ICU doesn't necessarily mean tele ICU. That is probably the very basic. So so you can have a Zoom call or other call with all the people in the ICU. That doesn't necessarily mean it is a tele ICU. So the tele ICU should also include all the smartness that we discussed so far, including data integration, including a very intensive data-driven EMR with automated reports, automated clinical scores, and all those things have to come in. So when it comes to tele ICU, what is more important is the concept of a central hospital with multiple hubs or multiple spokes. A hub and unit kind of approach automatically comes. So a smart ICU or a digital ICU platform should also support this kind of feature, where patients from across multiple cities, geographically distinct location, the data is able to see in real time. Data should be able to see real time, and all the data should be continuously available. The tele ICU should not be just a teleconferencing platform. Teleconferencing or a CCTV kind of approach is not a tele ICU architecture. It involves a lot of technology that you put in the background, not just the networking, but also how you send the data real time, how you maintain data security, how to make sure the system is up and running 100% all the time. All these things are really important from a tele ICU perspective as well. So once you have this tele ICU, what happens is 90% of the, rather 90, or I would even go close to 100%, 100% of the clinical decision or clinical care can be managed by expert doctors sitting in the central hospital. And things regarding physical care and duty related things can be given to the doctors or care providers in the smaller units. So this particular architecture is also being discussed in the industry a lot. I mean, we ourselves are doing a couple of tele ICU deployments, and there are a lot of queries in this particular regard as well. And when it comes to a country like India, where the reach of ICU care is not there 100%, tele-ICU architecture can not only provide better care, but also lower the cost of care and provide access to quality care to a lot of people. So that is a major advantage. You don't have to travel to the major city to get an ICU level of care. So this is a typical example of a command and center where you will be able to see all the live data and also have a live visual feed of the patient in the ICU. So that can be done. And there are also ways where we can have audio video communication with the tele unit. Sometimes I would like to say in one of our current installation, we are also setting up a robo. So this robo can be, this is not the image of the robo. The robo can actually, is enabled with LiDAR and other autonomous navigation technologies, where a doctor sitting in a remote place can ask the robot to go to a specific bed number 7 or bed number 3, and then the robot can move over there and then initiate an audio video call with the patient. So apart from fetching all the live data, as you see here, clinical data, doctors remotely will also be able to initiate an audio video call. So similar to the smart digital ICU, the smart tele ICU also requires real-time vitals and waveforms. So capturing these real-time vitals and waveform is very, very important. Without this real-time capturing of vitals and waveforms, tele ICU or a smart ICU is not possible. And of course, when it comes to tele-ICU, audio, video communication is also must. And people in the industry also talk about digital ICU rounds. You know, doctors should be able to do digital ICU rounds. And the availability of mobile app-based alerts and other related advanced functionality also should be there. And a remote central monitor and command center also must be there. So these are some of the dashboard from our application. Our application is called ZMIT. I have tried to make sure that today's presentation is more generic, but these are some of the images from our software screenshots. And I would also like to focus on AI. See, when it comes to AI, there are two opinions. One is, yes, AI is really useful, but there are other set of people who also say, you know, AI may work, may not work. So the point here is there are certain cases where AI can be definitely be used to assist doctors in making clinical decisions. The two areas of AI when it comes to smart ICU, one is clinical AI and another one is the radiology AI. So when it comes to clinical AI, it is very important to predict certain clinical event, particularly sepsis. So sepsis and sepsis shock is probably one of the major killer of the patient in an ICU. A patient death in an ICU predominantly happens because of sepsis. So if the care provider, doctors, can be alerted about actual onset of these kind of clinical events, sepsis, 12 to 18 hours before actual onset, then it becomes really advantageous. So, and people also talk about certain clinical pathways and how we can make certain clinical pathways, follow certain clinical pathways with all these AI integrated modules, so that very specific, timely, advanced care can be given to the patient. So the second part is the radiology AI. So though the radiology AI, it may appear it is not directly connected with the care unit, but radiology AI several radiology measurements or records are taken continuously for a patient in an ICU, and it is important to provide automated tools so that, or a computer assisted tools so that things can be predicted automatically. For example, our software will be able to predict multiple pulmonary disorders with high percentage of accuracy, including COVID-19 and other pulmonary disorders. So these are some of the advanced things that are coming up, and the application will also be able to do batch processing, where you can process thousands of chest X-rays in a matter of few minutes. So I believe I have come to the conclusion. So as a recap, I just want to tell you a couple of things. When we talk about ICU, it is not just the ICU, but also the entire inpatient unit, emergency, operation room, wards, and ambulance. Everything can be made smart, or it is being made smart digitally with advanced data collection and advanced AI. Hello, everyone. So
Yes, sir. Thank you, sir. We can take the question and answer session in the panel discussion, sir. At the end of the session, we can take.
Thank you
if
so
there
much,
are any
sir, for
questions,
your
I will.
thought-provoking speech.
Yes, sir.
If there are any question, I will be able to answer right now.
Okay, sir. We'll just come back.
Okay, fine. Okay, then. So thank you very much.
Thank you so much, sir, for your thought-provoking speech. That was really informative. I would like to call upon Ms. Nitya Priya, Assistant Professor, Faculty of Management Sciences, to introduce our next speaker of the session.
Thank you, Shiny. It's my pleasure to introduce Mr. Mohammed Farooq, who has 15 years of extensive experience in the healthcare industry. He is currently the business head of Dr. Rela Institute and Medical Center, Chennai. Mohammed Farooq is known for developing the strategic partnerships, both public and private, collaborative healthcare solutions, developing sustainable tertiary care healthcare models for partners, and initiating for access to quality healthcare for all. His major focus is on improving the customer service, patient flow, patient safety, and corporate development. He has a keen interest in research and has published some of his works internationally. We welcome you, sir.
Thank you, Nitya, for that lovely introduction. Can you hear me, guys?
Yes, sir. Yes, sir. It's audible.
I hope you can see the file as well. Sorry. Yeah.
Yes.
So I'd like to thank SRMC to give me the opportunity to talk here today, in today's Healthcare Technology Summit, and be able to share stage with these eminent speakers. Actually, I'm an ex-student of SRMC, so it's nostalgic being a part of this. I understand that lunchtime is nearing, so I'll try to keep it as short as I can. Well, I want to quickly move through some basics. So in terms of business, have you ever thought or ever tried to make a list of the businesses or stores that you visit repeatedly? Let's say you make a list of the 5 most common shops or stores that you visit in a month. If you had to categorize these reasons of why you visit them, it would surely fall into one of these 6 major headings. Number 1 is fast. The services are fast, it's convenient to visit, or it's in a place that you feel will get you the service at the quickest time, sorry. Number 2 would be quality, the quality of food, material, etc. The third choice, why you would actually choose a shop, would be it being user-friendly. It can be an app that you use or a store that you visit, like the Apple Store or something. Cheap is another version where we choose a shop from. A place with good service, with an acceptable quality, which you believe gets you a good deal. The fifth point would be luxury, where you visit the store or the brand or the product itself because of its luxury. Finally, customer service. I put that as a bit of a big slide there. This might not even crop up as the first thing in your mind, but makes a tremendous difference and may override most of the other reasons that we have. All right. That said, what's customer service and how is it different from customer experience? I'm taking it a bit from the basics on mine. As Mr. Ashwath mentioned in his talk, in short, customer service is reactive. People react to your problems, your needs, and they try to help you with them. Customer experience, however, is something that's proactive. So people have to go out of the way to get you there. It's something like, let's call it VIP service. Yeah. All right, let me give you a basic example, something from a non-healthcare industry, just to put things into perspective. All right. Yeah. Let's say I call Airtel customer care or maybe Citibank customer care, and I'd like to report a problem with the transaction. The customer care agent would go, "Good evening, Mr. Farouk. Thank you for calling Citibank. How can I help you today?" I'd say, "I've got a problem with one of my transactions," and he'd say, "He's sorry to hear that," and he would solve my issue for me. Now that's good. That's good customer service. However, imagine that I'm calling American Express with a black card, the MX black card, the very popular card. This agent would do pretty much his work, plus he'd do something extra. For example, this agent would go, "Good evening, Mr. Farouk. Thank you for calling MX. What can I help you with?" I'd tell him my problem, and he'd be like, "I'm sorry for the inconvenience. Let me get this handled immediately." Then he continues to say, "Mr. Farouk, I've just noticed that it's your anniversary in 2 weeks. The last year you booked a table at the seafood restaurant at Taj. Would you like to consider going to the same restaurant, or do you have any other plans? I can, however, if you want, look at some more places and call you back at your convenience tomorrow to discuss." Now that's personalized customer service. It's tailored to my specific needs. The whole experience is different, and I would make it a point to be associated with such a brand. Okay. Now, before we move on to using technology and making sure how we can actually give people a better experience, first, let's just consider about the healthcare situation in India. Just going to minimize this. Suddenly lost. You can see the slide, Nitya?
Yes, sir. Yes, sir. It's visible.
Oh, perfect. All right. Okay, so let's talk about the healthcare situation in India. So India has got a large population. You can see an ambulance. Yeah, you can see an ambulance and a tractor, both stuck in traffic here. We've got a very young population, considering our population. This young population is extremely impatient. It's tech savvy, and it's becoming used to getting things on demand because of the other industries. There's also a wide disparity in economics. I mean, you can see, most of you will see this every day. You can see an Audi and a bullock cart on the same road. We've got an underdeveloped public sector, which has to be eventually overseen by the private sector that we've got. And India is bad with its insurance. We've got a very minimal insurance coverage for people. We've got high local competition, new hospitals emerging, and this drops in market share for all the hospitals already. Now, I'd say India has been seeing improvement in the international healthcare business, but this demands excellent services. And finally, hospitals have to maintain standards at par or maybe even better than the ones in the West. And they have to do this at a relatively low pricing. So these reasons explain why technology-driven patient experience is key to be able to get us there. All right. So even though patient experience can be achieved only with holistic and comprehensive solutions, technology can surely reduce the burden. It can considerably make things, it can make solutions faster. It can make them more comprehensive. It can make them safer, less time consuming, cheaper, and extremely personalized. Technology, in short, has made care efficient, precise, and timely. So as most of our my previous previous speakers has already spoken on this, I'm not going to take too much time on this slide. So everybody knows that technology is playing a key part in diagnostics today. Radiology scans, pathology slides are being assisted in diagnosis by AI. You've got complete operational flow systems and patient journeys completely being taken care again by AI. We're also using AI in predictive medicine, and we've been able to flag patients who are sick or who might fall sick very soon. And like I was explaining before, a lot of assisted procedures are there. We've got robo-assisted endoscopies and even surgeries. Right. So now I'm finally coming down to healthcare. So healthcare is one of those industries that everybody needs. I'm sure you'll all agree, but nobody really loves it. One of the obvious reasons is that sickness, everybody who comes in with either sickness, and that comes with pain, fear, and sometimes even death. So nobody actually likes it. However, in 2019 at RELA Institute, we wanted to change people's perspective to healthcare. We wanted them to understand that hospitals are not only for the sick, but they're also for people's wellness. We started a few wellness programs for the general public to participate. We had free Zumba classes, free yoga classes early in the morning for anybody who wanted to join it. At the hospital's open parking, free of cost. We also started free training for people who are keen on running for marathons or cyclothons. And if they were actually good and they started performing well, we rewarded them. Our only goal here was to achieve a healthy population. That same year, what we did is we introduced this Fitbit. I mean, it was a different color that we used. I've not got that picture, put another Fitbit's picture here. But we had a Fitbit that monitored how active our patients were. And these were patients who had to stay active either to lose weight or because they were not being active. So when people were compliant, we rewarded them. And once we started seeing results here, we later started including other factors like quit smoking, quit or reduce alcohol consumption, being active, losing weight, keeping to their diet, maintaining their blood sugar, exercising, and doing their physios as has been recommended by the hospital. So all these patients who did well and got better were rewarded by the hospital. We use multiple such modules, of course, with the help of biosensors, machines, and a lot of back-end IT to help us do this in a very large scale. This not only helped us help the patients get better, but it earned us a lot of patient loyalty, word of mouth, respect for pricing at the institute, because this was something that was done almost free of cost. It also improved patient-doctor and patient-hospital relationship. This is one of the cyclothon events that we were starting at our hospital. All right. So now, what is personalized care? So personalized patient care, we've tied up with this company called THB. I'm sure some of you might have heard about them. They've come up with this AI tool that sits on our HIS. All right. This integrates our HIS with our LIS, our CRM, and our ERP. The job is it's collecting all patient data. It creates profiles based on this data. It assesses the risk for each of the patient, based on the profile that it creates, based on demographic data, their symptoms, clinical data. It attaches this with a feedback system that we've got, all right? And we added this new customer wallet. We wanted to incorporate this so that we understood that we can ensure that, we can actually give patients rewards automatically if they actually did better. And then the system would analyze the behavior and recommend actions. So that's what it does in short. We'll look at it a little bit more in detail to understand how healthcare can be more personalized. All right. So the good thing here is we started collecting customer feedback after every touch point from patients. Now, this helps us tremendously. It helped us create systems that we weren't even aware of before. See, generally, the customer feedback is based on the overall customer feedback. So when somebody comes to the hospital, let's say a patient is visiting the hospital, and he's very happy with the way he or she was received, the registration process, the appointment waiting time, the doctor, the nurse, the billing, but seem to have a problem with timing at the sample collection area. Now, when you ask such a person for feedback, he or she might still give you a bad review, and we would never know where to improve, what to improve. However, this platform that we use, it collects feedback at each touch point, and this allows us to pinpoint the area where the patient might have had a problem, and to better assess it, to help us improve services and to make sure that it doesn't happen. The other advantage is the next time the same patient comes down, the system alerts the areas where the pain points were. So these guys can actually take extra measures, extra care to make sure that this patient has an overall great experience at this time, and he never complains about the same thing again. That's the whole concept of it. All right. Now, let's consider one of the patient journeys. So this is for cardiovascular diseases. These are pretty common. So based on the cohorts or profiles, the system, I'd say, okay, let's just say we are considering the patient journey for cardiovascular diseases. Okay. Now, each patient has got its own risk factors. And as you can see, the risk factors have been categorized into two different categories. One is modifiable and the other one is non-modifiable. The non-modifiable ones are, of course, things that we cannot change, it cannot be prevented or controlled. Things like family history, gender. The other category would be modifiable risks. These would be risks that we can actually target. We can try to ensure that some type of control or change can happen here. Stuff like smoking, stress, alcohol, BMI, diet, etc. Now, these are the things that we also target, to make sure that we can reward patients, to make sure that they are compliant, any which way. So this would give us symptoms. The system would take these symptoms into consideration. Based on these, the patients would either have the disease already, or they would require a lifestyle modification, or let's say they need medication, interventions, and or rehab. So that's what the system actually does. It categorizes them, and based on this, it starts communicating with the patients on a personalized level. But once we started doing this for various profiles, various disease cohorts, what was surprising was the fact that the system sometimes identified patients who had come to see a doctor for one problem, but they showed that they had another medical issue also. It's very common actually, but it misses off. So the system picks it up. It alerts the patient that you might have another problem. It also alerts the healthcare workers at the hospital, the admin staff, and the other doctor also who might have to see the patient. Not only did this improve the cross-referrals among our consultants, it also developed patient trust on the system. The patient thought that these guys are very thorough, even though most of the system, it becomes so easy because it was automated. Anyway, so now that we've got these profiles, what do we do? How do we start engaging with these patients? So there are about 6 categories where we can actually start, where the system will engage with patients. Potential patients, patients who might need these information, patients who are potential for screening services, patients about their risk for disease, about diagnostic markers, modifiable risk, and promoting self-care. Instead of discussing this, I want to show you the example of how the system would work itself. Yeah. These are some of the images, some examples of the text messages that go out to patients. We've also tried to now include this as part of WhatsApp Business and be able to send them as business messages. WhatsApp messages as well. Anyway, so these are automated messages. Nobody does anything. The system automatically picks it up and sends these messages to them. They're extremely personalized for each patient. So, there is a message on risk factors, and this is based on clinical data. The tool has identified people with the chance of this particular risk factor. For example, this one goes, dear so-and-so, high cholesterol increases your risk of heart disease. Talk to your doctor about having your lipid levels checked. lipid profile along with other cardiac parameters available in the advanced package. It sometimes also mentions about a tailored package that would suit the patient. So this also makes them feel that somebody's at least taken the time out to filter out what is the best service that they can choose from the hospital and then send it to them. And this again makes people, gain more trust on the system. Something about quitting alcohol. So this is sent to patients who take excessive alcohol or have conditions where alcohol cannot be tolerated. Or in this particular condition, to patients who've got associated issues like, for example, stroke. Then you've got educative messages, and these are sent to patients based on their needs. And most of them also give them personalized packages whenever available. We've got multiple other examples of messages, various areas where we can send them. In short, recommendations, exercise, dietary requirements, information on hospital, disease, condition, or packages. Now, all these messages are going out. They are extremely relevant to the patient that they go to. It's relevant to their visit or to a condition that they have or might have. And it gives a very, very personal touch to the patients. All right. So let's imagine you're going to Dubai or maybe Agra or to a wedding. What would you remember about that place? You'd remember only the things that were very memorable. Oh, okay. You might also remember the things that were extremely inconvenient, but mostly either one of the two. So we've associated with this company called Purple Grids, and they've come up with this amazing voice-based AI automation. So this is what Dr. Masood was trying to show us on his presentation. So we've still got this in our testing phase. We've put these Alexas in our suite rooms. The Alexas would play, of course, their favorite songs and would act as their personal assistant. However, this particular Alexa is a bit of a hospital's training. You can simply order a meal or a juice by, I'm sorry, I changed the slide, by asking it. I mean, you could just say, Alexa, can I have an orange juice? And if the juice is on the menu, it'll take up the order and it'll give you a timeline for the arrival of the juice. If not, Alexa would give you an alternate choice for the available juice options for the day. So you can choose from that. The progress of your order can also be tracked. I mean, we are currently using this to get food orders, room service requests, housekeeping requests, nursing complaints, billing information, calling PR people, and practically everything that IT as well. So this is our AI-driven bot that we've put up on our website. It's this one is also powered by Purple Grids, and this helps patients book their own appointments, both video and in person. By patient registration, verification, payment, everything happens in the bot, and it's fully integrated with our HIS. We've also got multiple corporate accounts which the bot will support. It's a pretty smart tool. I mean, you've got your WhatsApp web, you've got health packages, international patients. It covers everybody separately. If you're actually somebody from, let's say, Sudan or Oman, and you're writing that, it'll actually identify the country that you're from. It might ask you if you want to change your language. It'll give you information that is more relevant to you based on your region or wherever you're writing. Anyway, what's more interesting is it's an intelligent bot. So I mean, if you just type in, like you can see in the picture, saying that I've got a ear pain, the bot would automatically suggest an appointment with the ENT. Also, if you type, let's say, I've got a chest pain, like it's done here, the bot would read, I mean, it'd recommend contacting a cardiac specialist, and automatically it'll try to load the page, the current page that you want behind. Anyway. The other queries also is taken up pretty well by this bot. Let's say you want to find out about the car park, and I've just typed in there, which says, do you have a car park? And it immediately will say that there's ample parking space, and we've provided large parking space for the visitors here. You can find out about your lab reports. So what I'm trying to say is it's very personal. You can say whatever you want to type, you can. It gives you a very humanized feel. And most of our speakers here have been very closely associated and dealing with these bots as well. Well, that's pretty much what I wanted to talk about today. I'd like to end my talk saying that technology is the key here to improve patient experience. During this time of COVID, I mean, we've been pushed really, and all healthcare companies in the last year had the highest rate in digitization. And we have to make sure that we can provide services even through these tough situations, and we keep up with this digitized platforms in the future. With that, I'd like to end my talk, guys. Thank you so much.
Thank you so much, sir, for your beneficial speech. That was extremely useful for us. I would like to invite Dr. Bhuma Devi, Associate Professor, Faculty of Management Sciences,
Karen?
to introduce the panel.
Karen?
Ma'am? Okay, ma'am. Okay.
Can we take up a few questions? Yes, Dr. Shubha is here. He is one of our faculties here. Yes. Hello, sir.
Sure. Yeah, please go ahead.
Sir, you were talking about LCDP. The healthcare is now moving towards LCDP. And you also mentioned Zoho has got a drag and drop, and the software can be created just by drag and drop. So when you are saying all this, it's like open source. Somebody has developed it, and the
Yes,
algorithm is already available, and you are just using the workflow. It's like a workflow which you can just use it and add some JavaScripts or something, some control, and you just create the software on your own.
Yes.
So when you have open source code available off the shelf, and if you have all these types of facilities you already have, and the data security is another area where everybody is now under the threat of cyber crimes happening. So these codes, when they are written, they don't come along with the security measures also part of it. So how are we going to take care of this in future? How confident are we? How confident can we be in using such softwares and building our own applications? This question is primarily to Mr. Anantha Padmanabhan sir, and also
I think I answered
they are
this
also into
question
IT industry. Yes, sir.
Yeah. Can I answer now? I
Yes,
think I need to. Are you able to hear me? Yeah. I have answered this. I am hearing some background noise. Yeah. I have to answer this question in two parts. One is as far as the I am hearing some background. Yeah. Now it's better. Now it's better.
It's clear, sir. You can talk.
Still. Okay. I have this in two parts. One is about the technology. Please understand there are companies like Microsoft, Zoho Corporation, Mendes. They have developed the low-code platforms, and these code platforms are open source anyway, but they are the platforms which have developed their own software and algorithms. And once you use those platforms, you can drag and drop some fields which are abstract, have abstracted codes. Maybe one particular field has about 100 codes, 100 lines of codes which they have abstracted. If you call it as Power Automate, that is the low-code platform they have. And the Zoho talks about Zoho Creator as a low-code platform. So it is very easy for process owners to start that low-code platform. As I told you, top 10 platforms which you can definitely try out. Your students can try out. Our own professionals can try out. As far as the security is concerned, honestly, I have no problem, because these are offered as SaaS solution. Subscription. You can build these applications and host it on their cloud. And whether it is Zoho or Microsoft, they are all HIPAA compliant. It is more secure to keep it in their platform, and the platform rather than even doing it in your own. The breach can be more, and it can be easier if you keep it inside your platform, inside your data center. Now the trend around the world is to put it on the cloud. And once you put it on their platform, you can use it for multiple hospitals. Suppose your application can be applied in all the 10 hospitals simultaneously in a very, very agile manner. I hope I have
Yeah, you have answered
answered
that.
your question.
Yeah, you have answered. And when you say cloud and keeping it on their cloud, our data is with Zoho or any cloud owner, AWS or Microsoft.
Yes.
So it's all with them. They are going to create a schema and provide us with the user ID password, and we can use it.
Yeah, for that matter, now
once again, the contractual
yes,
commitment.
that is what, for your information, AWS.
Yeah, the contractual commitments we have, how are we going to ensure they have the best contractual commitments with the provider?
Yeah, they have the IPA complaint, they sign an NDA with you.
Okay. Okay.
They sign an NDA.
So we have to validate their.
That's what it happened. Yeah. But that is why that is why you have to go to some very established low-code vendors like Microsoft, Google, and Zoho and all that, where their security practice is very, very good. For your information, not allow any advertisement if you have seen, unlike Google or Microsoft. And they are very clear from the beginning. They want to keep their data, especially clients' data, very, very secure. So they don't promote advertisements platform. I prefer maybe a low-code platform from Zoho Corporation. And we have been able to develop a lot of applications during the.
So are they do they do a vulnerability test also? Do they do ethical hacking test on their apps? Do they give what is it?
Yeah,
they,
absolutely.
Okay. So for your information, yeah, for your information, I am a software
and you can talk to the support department basis. Yeah.
For your information, I am a software professional with 25 plus years of.
I am aware of that.
Okay. Okay. Because I am a cyber security. I was a cyber security consultant and still doing it. So
yeah,
I thought
I like Zoho.
Yeah.
Yeah. For your for your information, they keep security at the top of their mind.
Okay.
See, as a top, that is why you should go to the established, and that is very, very important. It might be maybe about 5% or 10% more expensive, but all these issues are addressed.
Okay. Okay, very good.
And if you go to Europe, they comply with this regulatory authorities. If you go to US, they comply with their regulatory authority. Tomorrow, the security code that is going to be developed for India, they will comply with it.
Okay.
Madam, just to add on to that particular point, especially clouds, there are different.
If you don't mind, I'll add few points to it.
But one thing I keep telling people.
Yes, sir.
Yeah, actually, there are different types of clouds, hybrid clouds and
Please
private cloud as well. So actually, whatever the confidential data and whatever are most secure data, you can keep it on your private cloud and take the general code from the normal open source cloud, what we were speaking about. So however, the security things will be in place, but you can have the in-house servers and maintain your cloud data in your organization internally. So healthcare is the major thing that is facing that type of challenges, and usually we go for multi-party clouds and we go for private clouds, and it will be like an hybrid cloud actually.
Yeah, right. Is it? Do you suggest hosting our database on our own, or do you suggest giving that option also to the cloud owner?
It actually depends on the enterprise decisions, depending on the budgets. So it's up to the organization to take a call on that.
From the
Type
security
of
perspective,
data, and the type of data.
Yes,
yeah.
exactly, type of data. So actually implementation of blockchain also is available. So actually wherever like you cannot
It depends
change
on the type of
because
data.
hashing will happen. So definitely there will be no tampering of data happening, and you cannot change the source code. So that will be a better solution. So it depends on the organization what they can take it up.
There is also a third-party people available who does come forward and do a testing for you. For example, penetration testing is there, like how this
One point
banking
about
softwares are there.
blockchain.
If the entire banking software is kept on the cloud only, because banking
Yes.
is all about money. Keeping the money in the bank in the cloud is more difficult. So they do a lot of penetration testing and other type of testing, and in order to they get their own certificates. So to be very precise, whether the balance between this thing, yes, there's a budget versus this thing. But if you have your own in-house mechanism to do a penetration testing and have a data
Yes.
security manager, suppose
Yeah.
every organization have a data security manager which is going to be made mandatory from now. And anything loss of any data, anything like that, the data security manager will be more responsible. So having data
Correct.
security manager, keeping everything very clear up to right, you can keep it on the cloud, but you have to understand the nitty-gritties about it to learn much better, and then you can decide between cloud or a virtual thing you want to have.
Thank you, sir. Thank you very much.
But maybe we should have a word here. Can I take 1 more minute to answer your question, please? I have been maintaining servers inside the hospital for a long time, but I found maintaining the servers in the hospital is more difficult than maintaining data in the cloud. Because if I have to have data centers in the hospital, and then I have to have these hardware engineers for that. And they are not specialized. You must understand the technology is so rapidly progressing that our guys cannot cope up with technology that is happening. So it is better to keep it on the cloud. But as rightly said on the panel, I think if there are some sensitive patient data, we can still host it in our own on-prem server. And the data which is not very confidential, for example, some infrastructure data and all that does not involve privacy and things like that, can still be hosted on the cloud and get across the hospitals in the group. That is why consciously, believe me, people like us don't get into the patient care. We just to the infrastructure so that to make the patient experience more better by working on the front end rather than patient care itself.
Okay. Thank you,
Okay.
sir. Thank you. And Dr. Masood, as Dr. Masood said, even banking data is on the cloud. But banks have the
Thank you.
have specialized. Banks are specialized in doing the masking of data. So that is from the beginning, the masking of data is the algorithm is very clear for banks, but not in healthcare industry. So if we can also bring in such masking of data, probably we can also have the data on the cloud and use it without stress, being the data being data theft or any other crime happening to the data. Probably the masking of data can be built, the algorithm can be built with also. Okay, sir. Thank
with
you
all
very much.
due respects to the banking industry, I have seen many cases where there has been a data breach and a lot of fraudulent transactions have happened even in the banking industry. Yeah.
Yes, sir. But still they have best algorithm for masking. In spite of that, Swift is and it is impossible to crack, but still happening. Yes. Okay, sir. Thank you very much. Thank you, sir.
Yeah. Thank you. Welcome.
Any other questions? Any other questions?
So we have a question from our students to Dr. Masood. So like, what are the challenges, the legal challenges that you face when you implement AI in hospitals?
Implementation of AI or any other application, it's going to be the same. Implementation is always a challenge, whether it's an AI or whatever we try to talk about. I hope other panelists are here will also acknowledge the same fact. There is a mantra we follow, how do people, because they don't like change. If you want to change something, there's a general job description is given to the particular front office guys or OT guys, something like that. Suddenly you bring a new software for them to utilize it and use it and put it into place. They're not going to take it because the current job description itself is too heavy for them. Specifically in a healthcare setup, it is much more challenging for them. It's always very difficult to build something inside a system and be a part of the system. We have different tools and mechanisms which we do. We have we call it standard ways. Always prescribed this. I'm a McKinsey guy myself, so we always prescribe a method called McKinsey way, which has got OS, MI, and MC, which is operating structure, operating infrastructure, and mindset mechanism. So we use these three kind of technologies to use them, play with the mindset, make sure that they're always aware that they are using something new or not, that reward them in the respective way and make them the heroes, the champions of that particular way. There's a long talk I can give about McKinsey way or the MIMC, but in that case also, definitely it is possible to do things like that. One example I can tell you itself is the ERP what we have in almost all our hospitals. Most of the ERP we have not implemented even 80% of it. Probably would have implemented only 20 or 30% of it, or maximum 40% of the ERP itself. So it's always a challenge to bring something new, but it depends upon the severity and criticalness we have to implement, and then we have to take it forward on that.
UK, sir?
Sir, you are here?
Yes, you're welcome. Yeah.
Sir. So this
yeah, I'm ready.
You are also
I'm waiting for the
about,
question. Yeah,
yes,
I'm waiting for your question.
Yes, sir. Thank you, sir. So you also mentioned that IoTs have come down drastically, the price have come down drastically, and things like that. But help me understand on the productivity scale, sir. What is the largest scale of productivity of IoT is currently possible taking? Because I myself have an experience in IoT. We made one product for the COVID product itself. We call it urban above and all those things are there, but we had a big challenge there. So when we do something like that, your own cost in India goes up. Importing is much cheaper. When you have your customize your own product in India, how do you match this cost to product ratio to the market? The idea is good, but the cost of the product is so expensive, looks so expensive that people said the product is good, but expensive, sorry, we cannot take it. This is a challenge we generally find in the market. What is your take like this, sir? Here?
But my experience has been that when you compare it to the building management systems that are Hitachi or maybe for that Siemens, I find that IoT solutions are very, very good. They are very, very inexpensive. And of course, I do agree that most of the IoT devices are imported right now, and manufacturing in India is expensive. But maybe as the volumes pick up, I think the prices will come down. But I can tell you, in a hospital, there is a potential for about 600 to 700 IoT devices in the hospital. Believe me, one, I have just made a computation, whether it is in energy management or environment management or patient tracking or patient monitoring system. I have made each hospital, there are 500 IoT devices can be put inside and then can be monitored through this platform or an IoT platform. So I think maybe that requires a little mindset change in most of the manufacturing organizations. Go to Hyundai, go to Maruti Udyog, everything is IoT enabled. So I am very optimistic about IoT catch up in the healthcare sector, and I am very will come down. But only thing is you have to do a lot of due diligence. Don't use IoT for everything, and don't use too many IoT devices. Don't give very expensive softwares, but you have to do a very, very careful study. And you should have a CEO, you should have a center of excellence to re-engineer the whole hospital processes. You have to re-engineer the whole hospital processes, eliminate certain processes which are not required, simplify the processes. Then on top of it, have these IoT devices and also the low-code platform. You are sure to be a success, And there are some cases which I can show it to you right now. So hardly what I have implemented building management systems from many of the multinational companies, no business is less than about 1 crore or so. But here in what say 8 and lakhs can do the entire automation in the hospital. It is possible. But I think you have to work very deeply and they must have a very good domain knowledge to do that.
Thank you, sir. That's what I wanted to know. The cost versus the production. For example, your cost for the IoT cost to secure a syringe pump should not go exceeding the cost of the syringe pump itself. So that is what I was kind of getting in for some information. But you clarified that the cost is not very expensive and it can be takeable.
Yeah. No, I would like to give an example. Example is you have ventilators, which is about 18 lakhs of rupees. We have a cardiac monitor, which costs about 3 lakhs of rupees. And if you can read those monitors, if you can track the ventilators for their location, and if you can also track them for their performance utilization, I think you can get 10 times over. So maybe infusion pump and syringe pump is a little low value in the whole value chain. You should look at ECMO machines. You should look at maybe cardiac monitors. You should look at ABG machines and things like that.
Thank you so much, sir, for giving your ideas and information on the questions raised. I would like to invite Dr. Bhuma Devi, Associate Professor, Faculty of Management Sciences, to introduce the panel chairman.
Good afternoon, all. So now we are in the second part of the summit, that is panel discussion. So let me take the privilege to introduce the chairman of today's panel discussion, Dr. Mahesh Vakamudi. He is our Dean of Faculty, Sriha, Chief Operating Officer of Sri Ramachandra Medical Center, and Professor in the Department of Anesthesiology and Pain Medicine, Sriha. So he has over 24 years of experience in the field of anesthesia for multi-organ transplantation and cardiac critical care. His vast experience in complex cardiac surgeries and his passion towards teaching has led to his recognition as one of the most prominent cardiac anesthesiologists, president of the Indian Association of Cardiothoracic and Vascular Anesthesiologists, and he currently is national advisor in the country. Professor Mahesh's passion demonstrated expertise from his work in culturally diverse healthcare settings as both COO and HOD of anesthesiology. While serving, he has developed effective systems and processes to meet challenging international and national standards in healthcare at Sri Ramachandra Medical Center, thus achieved milestones of accreditation by Joint Commission International and NABH for Medical Center and ISO for the Department of Anesthesiology, Green OT certification as well. His endeavor towards quality at Sri Ramachandra Medical Center created a robust structure called the Quality and Patient Safety Team, which identifies quality, patient care, and risk management issues within their current system. Hence, this strategy empowered leaders of the organization to work upon continuous quality improvement initiatives and innovations in patient safety to bring evidence-based patient care. Under his leadership, SRMC received the Best Patient Safety Initiative Awards by International Congress on Patient Safety Practices consecutively for 6 years in 2011, 12, 13, and again in 2020. His passion towards teaching and knowledge dissemination to budding anesthesiologists paved the way for conducting an annual CME program in anesthesia called RACE, that is Ramachandra Anesthesia Continuing Education, that has been awarded the best anesthesia CME in the country by the Indian Society of Anesthesiologists. Expanding on this concept, he envisaged and ensured the launch of a website with free educational videos and lecture notes of this CME called racelearn.com, which is a freely accessible anesthesia website. He has also been instrumental in the Department of Anesthesia at SRMC, conducting the only airway certification course in the country that is accredited by Difficult Airway Society, UK, and Society of Airway Management, USA. He has several national and international publications, has authored chapters in national and international textbooks of anesthesiology. He has been awarded as the Outstanding Anesthesiologist in India by the President of the Indian Society of Anesthesiologists in 2010. Having taken over the mantle of Dean of Faculty of Zoho, he brings his astute knowledge, vast experience in education, and research, and excellent administrative and managerial skills in advance that institute further towards the path of progress. I am proud to introduce to you Dr. Mahesh, a very simple, multi-talented, and humble man to take over the panel discussion. Over to you, sir.
Thank you, Bhuma ma'am, for that elaborate introduction, and I think I consider it really superfluous. It's one of the most superfluous introductions I heard about myself. I think it's all teamwork. I didn't do much of the work that you said. It's all the team. Whatever the teams that were there, it was all probably because of the teamwork entirely. It's actually heartening to see the very elite panelists today, and I feel I would rather be on the delegate side to learn more from them rather than to be on the panel to chair this panel. You know, that's probably more to learn rather than to actually chair and talk about this very important topic on application and use of advanced technologies in healthcare. One of the topics that I really like in the last a decade or so, I think there's so much of focus has been put on the using technology to transform the healthcare. I think that's the results of those focus we are going to see in the next decade or so. The fruits of this focus that has been put on using technology in healthcare. There is so much to be seen in the next decade. I'm very, very optimistic about it. I know so much of advances that are coming up, at least in a dozen areas, which I know, out of which about 2 or 3 I'm quite involved with it. Today, let me take the privilege of actually introducing the very elite panelists that we have today. The first panelist we have is Mr. UK Ananthapadmanabhan. He is a graduate in electrical and electronics, postgraduate qualification in business management from LIPA. He is the director of a healthcare IT startup company called 10x Health. We all know that so well about him at Coimbatore, which is involved in design development and implementation of hyper automation solution in the hospitals. He's actually involved in teaching, training, and research in the field of management, and is visiting faculty for many postgraduate institutes and universities. Our second panelist is Dr. Masood Ikram. He's a doctor turned entrepreneur. I'm always a fan of somebody who is a physician and turned into an entrepreneur, Dr. Ikram. Excellent thing. Who after completing his MBBS did MBA in healthcare management from Manna University. He was instrumental in setting up the startup, the TechMed Laboratory, which has grown from a 30-employee startup to an 800-employee multinational company. His new ventures, Melon AI, is born out of his passion from innovation and technology. He is also the assessor for the most coveted Malcolm Bridge National Quality Award. Excellent. The third panelist we have today is Dr. Mohammad Farouk. Mr. Mohammad Farouk has over 15 years of extensive experience in healthcare industry. He is currently the business head of Dr. Rela Institute and Medical Center at Chennai. Mohammad is known for developing strategic partnerships, collaborative healthcare solutions, developing sustainable tertiary healthcare models for partners and initiatives for access to quality healthcare for all. His major focus is on improving customer service, patient flow, patient safety, and corporate development. Another area that I'm very, very, very passionate about in my day-to-day work. The fourth panelist is Ms. Diksha Singatuvan. Diksha leads technology adoption in hospital healthcare ecosystem at Kaveri, improving access to the affordable healthcare. Right after her PGDM in Indian Institute of Management, Kolkata, Diksha joined the prestigious Tata Administrative Service Program. Welcome, Dr. Ms. Diksha, to this program. We're all looking keenly to hear from all of you. May I request Mr. Anant Padmanabhan sir to actually start the discussion on this panel, to lead the discussion, sir, now.
Thank you, Dr. Mahesh, for so generously introducing me, and it is a great panel to discuss on technology in healthcare. I have been working in the hospitals for over decades now, and I was I was more a I started my career as an operations manager. Then slowly I moved into the senior level leadership and started looking at technology. When started somewhere in late 90s, we used to go around the hospital, operation theater, or whether it is laboratory or whether it is an intensive care unit. We used to keep visiting the places and trying to understand what is happening and try to improve processes and help the doctors and technicians and nurses at their work. But as you saw over a period of time, the 300-bedded hospital became a 500-bedded hospital. Maybe yes, one standalone hospital became a group of hospitals for us to manage. Then not only hospitals, we have clinics to handle them. So it was becoming at the group level to manage all these hospitals physically going around and seeing. And it was at that time, I think the computerization was also catching on, and we were very excited when we saw a computer for billing and somewhere in 90. Later, around the 2000 and Y2K problem came in, and after that the internet came in, and I think that really changed the face of healthcare in my opinion. So after the internet coming in, then we said, okay, that is the best thing that we can network all the computer systems in the hospital. We could network all the computer system in all our group hospitals, and it was a great achievement at that time. But I think in the last 5 years, I think there is a huge change. We talked about, so much was talked about in the engineering industries, but definitely not as much in the hospitals. I still, in the corner of my heart, I feel healthcare has not adopted technology as it. But thanks to COVID, that people have become very aware of healthcare. Technology has become the focus in healthcare. People who did not talk anything about healthcare are talking more and more about health, technology in healthcare. So I think government is also focusing on health technology. But as you know, our infrastructure has not been very good. In the COVID-19, our infrastructure almost crumbled. But you may ask me, what is the relevance for technology? As you know that we have hardly about 15 lakh beds and beds in the next, say, 4 years' time to meet the WHO standards. But along with the infrastructure, what we must understand is when we develop infrastructure, we should also not produce to waste. I am very concerned that whenever we produce infrastructure, don't use those. Government purchased about 2,000 ventilators and infusion pumps and cardiac monitors, but many have not been even unboxed, and many of them we don't know where they are, whether they are being used. So I think along with this opportunity of creating health, I think there is also a lot of opportunity for improving the IT or technology in healthcare, and that is where I see a huge opportunity. And it is just not about IT. It is just not about HIS. It is not about EMR. It is something we should look at the entire gamut of IT in the hospital, from the time patient enters the hospital to the time he goes to the OP, goes into the diagnostic areas, gets treated maybe in an operation theater, surgery done, maybe even after he gets back to the home, how are you getting connected? And another interesting area where IT can be very useful is in health insurance. I think still we have not used IT and health insurance. Looking for a day when you see a bill of about, say, 80,000 rupees or 90,000 rupees as equipment charges, and if you see about, say, 50,000 rupees as operation theater charges, 50,000 rupees as ICU, can we show to the insurance company, to maybe a low-code platform, to track all those patients as they come inside the hospital, as they go into the OT, of course, taking care of the privacy. Of course, taking care of the privacy. If we could give an online access to the insurance, the way he has gone around his patient journey, and what was the time he went to the operation theater, how much you have charged for the operation theater, how many you have connected, what was total time that was connected, how much you have charged. If we can give a complete visibility, I think it will definitely introduce a lot of transparency and in the process, the costs will come down, and you will really see the benefit of technology in that space. But if you ask me, what about electronic records? What about artificial intelligence? My only concern is scenario in India today. Out of 65,000 hospitals registered in the Ayushman Bharat, I don't know, at least only about 10 to 15% of the hospitals have a good valid HS as some said, and that too, if the HS are there, it is not fully utilized. Where do we stand for introducing AI in the hospitals? That is a question I pose. I want really answers from the eminent panelists, whether it is time for us to use AI, whether people are prepared for AI, whether it's right to apply AI in the healthcare industry. Thank you, Dr. Magesh. I wanted to say as an introductory remarks.
Yeah,
I'm done, Doctor.
That was in very crisp introductory
Hello.
remarks. Can you hear me, sir? Am I audible?
Yes, sir. Yes, sir.
See, that was a very crisp introductory remark.
I am able to hear you, Doctor.
Yes, I think
yes,
two important points I would like to stress in what you actually said. One important thing is technology is one thing. We understand the technology is going to take us to the next level of delivery of the healthcare. We're going to move from, it's my strong conviction, I keep talking this in many forums, we're going to move from an episodic and acute care of healthcare delivery systems that we have to a value-based healthcare systems using the technology, which is the demand from the patients and society right now. That's the kind of healthcare that if you look at the second curve metrics which the developed countries already talking about implementing across the healthcare delivery chains, we need to start looking at the same thing. We are talking about the value in terms of the patient outcomes, not just the mere episodic outcomes or the acute care outcomes. When we want to do that, your first point that you raised is a very important thing. The people who are actually both stakeholders in this in developing this technology should have the real-time experience on the floors of the hospital. You just can't sit in an area which is an aloof and a silo, which is different from a setting of a healthcare setting, without even understanding about the solution is being developed basing on what practical issues that you have, or the end user issues. When you said that you actually used to visit the intensive care units, operating rooms, patient care areas, billing areas in the early part of your career, I think it's important that today all the healthcare technology developers should start working integratedly with the healthcare delivery networks on the floors of the patient care areas. This is my very important point, and I keep talking about it, stressing it everywhere. The other important area that you talked about is the health insurance and then IT. I'm very much 100% in agreement with you. You can actually do 200% more with insurance right now than what we are doing in terms of integrating health insurance and better healthcare, developing healthcare models. Actually, the payer-provider relationships could be entirely different if you start using the technology and then using it to the best of its potential. Well, yeah, let us listen from probably Dr. Ikram about AI, because he's the AI expert on the panel right now. And then I'm sure there are at least there's a good progress that's been made in the AI, and we're going to shortly see, for example, the prospective diagnosis and the predictive diagnosis models are already in place in the developed countries. We might be seeing them in Indian scenario too shortly, and I think few of hospitals are already running projects on it. May I request Dr. Ikram to talk something about the AI and how India is actually is India geared up to actually taking the AI and putting it into the healthcare delivery and then improving outcomes and giving better patient experience? Over to Dr. Ikram.
Thank you, Dr. Mahesh. And yes, a lot of discussions have been talking about AI. And when talks about AI, it becomes very sensitive also, because Elon Musk says, be careful with AI. Sundar Pichai says the future is AI. A lot of people have different comments and different views about AI. Me, I've been worked in AI for the past 2.5 years. First of all, there is no threat from AI. AI is not going to replace anything. And we have got our own challenges. We have to see where are our challenges and we take it forward into it. Before I would say something about the future of AI, I'll just list down the kind of challenges we are having currently facing in our country and probably in other parts of the country. Majorly, I will classify my challenges into 4 different ways. First part is your information. Information is your data. That is for part 1. Second part will be your technology and adaptation of the technology. What are the technologies available in AI? Do we have it in India? Do we have the resource in India to have those technologies in India? Third part will be more of the usability, adaptability. Are they ready to use it, adapt it, or something like that? So come to the first part, the information. I took a 40-minute session basically touching the challenges of AI in India is the data itself. Unfortunately, India being such a big populated country, we don't have to worry so much about data because enough amount of data is available everywhere. Unfortunately, we're not capturing enough amount of data. UK sir already said that we don't, though we have Ayushman Bharat, there are so many hospitals. We don't have an ERP, then you're not tracking all the data. We're not tracking all the data. Data is the mining of the entire AI. So without data, we're not able to go forward onto it. That is challenge 1. Same time, I'll tell you the solution for AI. Again, the innovators, like, data is seen in 2 different ways. One is retrospective data and one is prospective data. Even if you don't have a retrospective data, let's see about the prospective of the data. If you start taking data, accumulating of a data from today onwards, you're going to have some amount of data from the previous and some going forward on the data. Now, what happens when you don't have enough amount of data? The accuracy of the particular outcome might not be good enough. Instead of starting it with 100% accuracy, you will be starting it somewhere around 60 or 70% accuracy. But what I will recommend is, even if you don't have enough data, and the outcome of data is giving only 60% or 70% accuracy, please go for it. Please go for it, because there should be somewhere, there should be a start. With very minimum data we have, we're going to start with this particular AI application. The 60% of the data, there's something called reinforcement learning. AI has got something called reinforcement learning. That is like, it gives you an output. If you're okay with the output, you say yes. Not okay with the output, you say no. The reinforcement learning is much faster. So suppose you have 100 data and you have 10 reinforcement of data. The 10 reinforcement data is equal to 100 again. So you've got 200 amount of data coming into the picture again. So never worry about the information you have or you don't have. It is a challenge, but whatever minimum basically you have, we can still start an AI program and it can definitely serve a lot of people. That is part 1 of the challenge. Part 2 of the challenge, if you try to understand the technology per se itself. I also mentioned in my previous talk also that, most of the people, like most of the CEOs or the major company people, like even from Apple to Google to Microsoft, we have Indians in a larger position. But why is that in India we don't have a good technology people who can take up AI and go forward on it? So basically the answer stands here is, we have n number of engineering colleges in India. We know the numbers sometimes seats and sometimes doesn't get filled about it. Then what happens when they complete their UG? Do they have the right amount of PG? Do we have good amount of PhD for AI? Even if you have PhDs for AI, what are the capacity and calibrity of the professors who are taking this particular AI into program? So we have this big lack in the technology development and technology availability in our country itself. I had to go through this particular challenge. There was one Indian born who was a Belgium citizen living in somewhere in Belgium. I said, I begged him, please come down to India. We need a lot of people like you to come serve the country here. We have come down. Likewise, other people, other companies, I know some of my friends who are doing AI companies are having a similar challenges. You don't get a good resource in India. We go to different colleges, we conduct hackathons, we conduct programs, we conduct challenges, we filter them. Still, we have to infuse a lot of technology inside them for them to deliver the way we end up looking in for. This is part 2 of the challenge. The part 3 of the challenge is something we've already discussed, that acceptability of the particular technology. Some people say yes, some people say no, this is there. For example, I tell you one thing I did 6 months back. I went for an poll for the number of people in the healthcare industry, asked them, AI is not been able to implement in our country because of the 3 reasons, major 2 reasons. One reason is, I have a threat that AI will take over doctors. Second thing is, I don't have enough knowledge about the AI. Guess what? 70% of the people said, I don't have knowledge on the AI. That was the outcome of the poll. That means the people are not worried about the AI is taking over them. That is one. But still, there are 30% of the people in the country still feels that AI can take over whatever jobs we currently have. Even they have to get educated. In this point, I'll come forward and I'll thank Ramachandra for this kind of a program to come forward and desensitize this particular thought process of the people that AI can take over a lot of things about it. So, having said all this, I have been building so many AI platforms. I have multiple applications is what I have, and it is motivating us and it is giving us a lot of fuel. We can definitely go for 5 years from now. So things are promising. They're challenging, but things are promising. But someone had to lead it, take the step, and go forward into it. Last, I will take Sir's question on that. When you don't have ERPs in different hospitals, how can AI can go into deep inside and like that? Yes, sir. We don't have ERP. That is a lack that we don't get data coming from those kind of regions from there. But having said that, AI is not about ERP alone, sir. We can have multiple applications sitting on the server, and not just tier 2, even tier 3 cities, different locations. People can use our applications in different ways and can make use of the AI which is available here, sir. Over to you, sir. Thank you, sir.
Yeah, that's a very, very apt and accurate information about the AI and challenges of AI in the Indian scenario. Just a couple of thoughts on this topic. One is, you're very right, actually, when you talk about the big data available in this country. And I keep talking about it all the time for many years now again. Just I keep giving example of my own areas of work. We do about close to 35,000 anesthetics a year, for example, in the areas that where we work. And I keep talking about it. If we can actually capture 1 year data on that particular 35,000 anesthetics, for example, I'm saying in a hospital, what we're talking about, in the whole country, in Chennai, in Tamil Nadu, in Chennai, in Ramachandra, in Chennai, so Ramachandra is one hospital. In one hospital, you're talking about, in one area, you're talking about some 35,000. Imagine the kind of data that you rightly said, in what the kind of data that you have in this country. But again, you're right. The data that has actually no outcomes has no meaning. If you don't have a reports, you don't have the, you don't do appropriate data mining. I think data is useless. How much of the data you have? First of all, we don't have mechanisms to capture the data you have, and you can't make any good meaning out of the data that is, if that's available anyway. About the talent dearth, yes, we have been going through it, and then I think it's a serious issue that we have. We lose good talent to abroad, and then they settle there. About the usability and adaptability, I have a small doubt here. Why do you think that's because the same physicians are there? I find that if you look at for example, the electronic medical records implementation across the most developed country in the United States, the healthcare is so advanced. It's not more than 50% even there. I mean, even there, the usability is not very great in terms of the healthcare personnel coming forward to use it. If you look at again, the physicians or the nurses trying to use technology, they use the technology all the time, every day. It's not that they don't use. They are. I know so many physicians are tech savvy. They're probably much better than using apps day and day. They get used to Twitter accounts in about, if you introduce them, I'm sure a lot of guys in the last few years have moved to the Instagrams. They learned it very fast. If they want it, they can learn it. It's how it is. I think that the technology has to take it and push it across into the domains of the healthcare delivery systems. I think we have no other go except to push to make sure that the AI makes an impact on the healthcare delivery. The resistances would happen, definitely, as we always have seen when we want to implement an electronic records inside the healthcare. You see, there's a lot of resistance, but I think we should probably push it across using what are the means that we have. The technology has to be pushed across. That's what I feel. I think it's an important point that you raised, but I think these are the challenges that we have to probably go through. I just want to ask you a couple of things to you about use of right now. Are you aware of any major projects that are being run on AI in India in terms of Google's DeepMind? One of any of those projects in this country? Anybody is doing anything major with AI in the country as a big time projects?
So a lot of companies are already working on it. IBM Watson is one we must have heard of. They're doing a wonderful job already. But I'm very fascinated with one program which I want to mention it here is Apollo's healthcare program is going on. They're trying to replace, they call it Pro Health, basically, Apollo Pro Health. So I'll take a minute here to explain that also. It was one of the beautiful concepts which I visionized it once, but good that Apollo is doing it now. So what they have done is they're going to next level in master health checkup. So what they have done, they have taken all their employees, 35,000 employees and their family members. Okay, they have taken it them for free. They have taken the blood testings and taken the entire data of those people, and they want to predict who will be the next diabetic guy. This is what they're trying to predict. If you're already diabetic, who will be the guy who going towards the retinopathy or nephropathy or whatever thing? I'm just giving you one example like this. So this is what they are trying to predict from the family members of the people what they are going in forward. Initial stage for them, accuracy is not coming to that level. But as I said earlier, it has to have a start somewhere. I'm glad that they have started it. And there are other companies even Farooq mentioned a couple of things which Rella has already been implemented and is using forward. And people are in a nascent stage trying their hands in a lot of different places, sir. And Diksha in her mention, she will also mention a couple of things which they have already been working on. In fact, Diksha's major concept is to bring more technology inside the concept. There are things, sir. There are wonderful things. Probably in 5 years down the line, you will see a big, huge amount of impact coming in.
Yeah, I mean, I think you're right. Actually, in 5 years down the line, we're going to see a lot of AI models, and especially in predictive health, would come in and take over a lot of areas in healthcare delivery. May I now move on to Dr. Farooq? Ms. Farooq, I mean, maybe we can hear from you about what is it that you in your opinion that you would be thinking of in terms of the technology and healthcare delivery systems. Is there anything that you're actually working right now on, and what do you suggest the way forward for this country? Because you're working in one of the best setups, probably one of the most clinically intense areas of medicine, and most leading one of the best leading hospitals in that area in Asia. I think you can actually give us an oversight about using technology in clinically intensive hospitals. What is your take on it?
Thank you, Dr. Mahesh. First, I'd like to thank you. I mean, even your introduction was perfect. It was lovely, actually. Thank you for that. Actually, I would say that you've correlated the whole thing that I wanted to talk in just one sentence of yours just before Dr. Masood spoke. You said that healthcare needs to be more value-based. I think that says it all, really. I mean, AI is the future, really. AI, I mean, we've got multiple things that are coming up. We are coming up with biosensors and everything, and then it's all going to be it's all going to be integrated. You've got IoT working up. You've got actually even electronic medical records is not fully established in our country, and most of the hospitals are getting there. AI, I would say, is extremely important. I mean, we are using a few tools. Actually, we're using a few chatbots. We're using voice-based AI tools, and they work exceptionally well. Of course, again, these are the smaller versions of AI that we are seeing. I mean, instead of the bigger picture, which would be actually being able to provide healthcare in places where doctors are not actually available. Imagine countries where you don't have senior doctors, but they need diagnostic tools. Now, sending people there or putting up camps there, all of that becomes extremely difficult. However, if we can use this technology to reduce that burden, that itself would actually improve healthcare across the world. You were talking about DeepMed, DeepMind from Google. I mean, those guys have worked out on this beautiful breast cancer AI tool. I'm not sure if you've heard of it. It's on point, actually. I mean, last year's publication shows that the results, I mean, they outperformed all human radiologists by more than 11.5%. It's a big number, actually, in terms of something that we've been doing for so long. So technology has to be the key. I'm more into, I mean, of course, I'm more on a business perspective, not too much on the IT side. But what I believe is now, I mean, healthcare, we are an industry where we are very centered on the industry itself. For example, every hospital wants to make sure that they get better in terms of making their processes better, making their clinical status much better, making sure that the diagnostics is faster. It's not patient-centric, really. I mean, when you look at any other brand other than the hospital industry, they're all extremely customer-centric. And we are not that customer-centric yet. And this is where we need to get. And this is also a key point, which, because of the other areas, I think will still be a bit slower to develop in our country, I believe. But I think that becomes extremely important, considering that competition is growing. You know, we're getting new business from the West, and our standards of care are increasing. So I think most of this can only be reduced. I mean, most of the burden has to only be reduced by the technological advances that we are making. And I think AI is one of the key things there. I mean, I'm a fan of AI, so I might be a bit biased as well on towards that, I have to say. But we've seen a bit some of their results, actually. I mean, considering using that in drug discovery, you know, is exceptional when you consider the time that it would actually take you to do, you know, and trying to understand that you'll be able to help a population which is much, much bigger. So, I mean, when you're taking the bigger picture into consideration, I think that is the way forward. I'd like to end with that, Dr. Mahesh. Dr. Masood, I wanted to find out if you guys have started working on any kind of a tricorder yet in India.
Yeah. Tricorder?
Tricorder. Yeah. A tricorder, you know, I mean, to analyze various diseases together.
Yeah, I mean, it's something like from your Star Trek movie.
Yeah, slightly.
We're not there yet, I guess. I think we might be. We might
be
not
there yet.
You'll never know, sir. Dr. Masood is going to be coming and just opening his. Look, I've got one, but it's still on testing phase. That's what I was expecting out of him at the moment. But then,
of course, there is a huge number of wearables now available across. You know, I think we are probably we might get better in this in the next couple of years. I guess, you know, I think there's so many iterations that come up now. Right now, in fact, again, I would probably share that with the panelists. Like I was trying to get a fingertip pulse of the cardiac output monitor that you can actually get it onto your fingertip. In my personal opinion, again, you know, looking at the technology and the intensive care, it would probably change the way the intensive care could be managed and the outcomes would be managed if we can get that kind of technology across, you know. But there's a time. Right now, they're able to get the blood pressure with the miniaturizing with no cards. You know, you don't see there's any of those big cuffs there anymore. It just gets onto your fingers, and then you can, without any cards hanging around, and then it can actually give it to you onto your mobile platforms in the HS, wherever you are, in the real-time data. All that is is coming in now, but not into the real-time practice yet, I think. But you can answer that question about the, I think UK sir is asking about the tricorder. Dr. Vikram, would you like to talk anything about that?
No, sir. I think UK sir will be a right person on IoT devices. Sir.
Yeah. Sir is here actually. So can you hear about it? Can you hear what Dr. Vikram is saying? Okay. We'll probably talk to sir when he comes back. May I now probably ask Ms. Diksha to talk about one thing I liked in your profile is about the affordable healthcare and technology. I think it's let's move out of the AI for some time and talk about affordable healthcare and technology, which is probably the most important thing for this country, in my opinion. How can we actually I mean, this is what I've been talking about, and again in some other forums. How can you keep patients out of the hospitals using healthcare? This is what I always talk to people. I know it's a very my direct finance hears this out. You know, he'll probably get upset about it. But anyway, I think we have to move on as a society. It's very important. You know, we need to look at how do you keep patients out of the hospitals. That's automatically making your healthcare affordable. How can you avoid readmissions into the hospitals? You know, avoidable readmissions. Can you use technology about it? I'm sure you have. I know Kaveri has great leaders in healthcare. I know that with somebody sitting like Manmohan there. But I think I'm sure you can share some of the stories with us today, Ms. Diksha.
Sure, absolutely, Dr. Mahesh. I don't know how you have like that accuracy of pinpointing exactly what the person is looking to talk about. I think Mr. Farooq also said that, you mentioned a great line. So, thank you for focusing on the value-based care part and especially bringing healthcare outside the hospital, right? So, we've always been now looking to how do we move away from healthcare to wellness care, I think is what we are speaking about. So you rightly mentioned one of the key things when you're talking about making care more affordable is when you're looking at, taking one particular scenario, you're saying reduce readmission rates, right? So as you mentioned, Dr. Manivan is very passionate about that. So in that sense, I think Kaveri has had good direction from the leadership that, what we want to focus on is not on making patients, stay longer or take more services from us, but ensuring that they're, safe and well. So when it comes to reducing readmissions rate, you have multiple technological solutions that sort of play into it, right? So one of the things that we're using right now actually is a post-discharge care module where so it's a combination of technology with human touch, of course, right? So we call the patients, we understand regularly regarding the symptoms that they're facing as per each surgery that they've had, and we keep constantly tracking that every 3-4 days. And the setup the system that we have helps us with a predictive analytics tool, right? Nothing complicated like AI, like, sort of building intelligence, but more of saying that, okay, if someone is having these symptoms continuously, then, time for an intervention, right? So what that helped us with was in the early intervention part. I think the key to reducing the cost of care and to make it more affordable is to ensure early intervention, right? So when after they've gotten discharged from the hospital, sort of regularly tracking the symptoms of patients and using predictive analytics methods to say that who's at a higher risk and hence whom do we need to bring back to the hospital for an intervention so as to avoid an admission later, right? So I think that is one of the places where technology definitely plays a role in helping us understand and categorize the risk parameter for each patient discharged. The other thing when it comes to reducing care by early intervention is from when they are inside the hospital itself, right? Having clinical triggers for tracking adverse events. Now, this again comes to how much ever data that you capture from the different situations. But when you have it in a structured way, you can avoid multiple complications by preempting adverse events, right? So avoiding deep vein thrombosis is one of the use cases that we worked on by tracking, certain parameters to see when that will sort of get triggered. And reducing acute kidney disorders by tracking urea creatinine levels in the patient's lab reports, right? So the minute we see a spike, we sort of inform the clinical team that, there is a spike, you might want to look into it. So I think clinical triggers, again, all of this in the back end is powered by the technology where we are coding and sort of tracking the different parameters and then, sort of prompting the clinical team. So I think this is one of the areas where it helps us, preemptively address patient care and hence reducing the number of days a patient has to stay within the hospital, reducing complications, which all ultimately reduces cost. And the third point, I would say, third and final thing sort of when it comes to reducing care, and it would be before they visit a hospital, right? How do you track patients' health and ensure that they don't actually have to come back to the hospital? And that is where I would say simple technological solutions that other industries have adopted way back, something as simple as a CRM, right? Where you have a patient profile, where you know that when has the patient come before, what are the ailments that he has, has he checked again, if his HbA1c level is above 7.5, did he come back within 3 months to sort of monitor it? Is he keeping track of his health? So that is something that we can work on for the patients. We can nudge them, right? Where we are looking at all of this data, we are nudging the patients and hence bringing them to the hospital preemptively, not for admissions or anything, but just basic checkups to ensure the health is on track. And this will avoid any further complications or future admissions for that patient in itself. So I think these areas I would say cover what you captured in a nutshell about providing affordable care, which is what I think we are very passionate about. We're looking at how do you reduce, and I think hospitals adopting some basic solutions such as this would help us a long way in reaching that. So I would say
That's fantastic. Actually, some couple of points I really like from what you said is about the clinical triggers. I think that's a very crucial point in my opinion, because the clinical triggers are the ones that could really help patients moving into a more critical situation. If you have those alerts. Of course, in our accreditation terminology, we call it as clinical alerts.
Right.
Those alerts should be converted into a clinical triggers. Critical values and alerts. That's what we talk. You can convert that into one triggers so that you can actually initiate a chain of interventions, so that the patients can be prevented from actually getting into more sicker state. And also, that actually leads to your other point about preempting the problems. You can actually preempt the care and then make sure that the patient doesn't get an. I always talk about, whenever we talk about problems in hospitals, I say take up your maximum LOS patients and find out how well your hospital processes are running. That'll show you how good your processes are. That's where I feel the technology should come in my opinion. If you can implement your technologies, and the proof of your technology working is in reduction of your loss in long loss stage patients. Well, 50% of them or 60% of them could be rightly staying longer for the complications beyond the our care. But how many? I always again say, how many errors per million opportunities can we reduce by using technology? That's the crux that we need to look at. The last point I would like to probably ask the panelists to share on their thoughts on. We talked so much about the clinical care processes. What about the non-clinical care processes that the technology would help on in patients when they visit the hospitals? That will really improve the patient experience. If you look at patient feedbacks in most of the hospitals, in most of the established hospitals, the clinical care feedback is not that bad. In fact, most of them give 9+, 9.5+, or 10+ for the physicians, nurses, and all. They give kind of very poor ratings on most of the administrative processes. Most of the non-clinical care processes experiences that they would have gone through, especially insurance, discharge, billing, the communications. How do you think that the technology would take care of this? Because this is one area that we have to start looking at, and if you want to improve the value, especially in the current day scenario, if you're going to actually reduce whatever you see in the media and we see in the real-time scenarios, that there's so much of onslaught, the patients actually their rebellious attitudes on healthcare professionals. If we want to reduce it, in my opinion, the communication systems, the healthcare technology should come in and then help us out in communications. Where we should be able to establish better rapport with the patients. How much you think the healthcare technology can help? May I ask Dr. Anand Padmanabhan sir if he's listening to this discussion? Sir, are you able to listen to us? Dr. Ikram, can you come in before sir can come in?
Yes, sir. Actually, to answer you, I get into perspective, sir, because actually the more operational tools are more potential for us than the clinical tools. Frankly, that is the situation today. Why? Because clinical tool has to go in a lot of trials and testing. There are no adaptability. A lot of things are there. Accuracy levels are going to be there. But whereas in hospital operational level tools are much more in the market and much more in demand for us. We have developed a lot of tools for the market in that case itself, sir. One such product is we have this AI cameras which we have given it to a couple of hospitals. We've given it to more than 4 or 5 hospitals by now. So what they do is they recognize the face and they also recognize the patient's feedback on them. How many people are happy, how many people are sad. So we get to know a real time how many people are happy, how many people are sad. At the same time, we also have blacklisting with them. Blacklisting is, suppose a patient or somebody, you have blacklisted them, you don't want them to come back to your campus again. It will give you an alert that this guy was blacklisted once. So that is one of the tools we have given. We have other tools like patient estimation of the patient's bill. So your patient is coming in front of you, you give them a number and then it comes later. The numbers are different. So that brings down your service level. So we have a product called Fair Bill there. We have got diet products, which can help you build the diet. So we have built a lot of products. More so, we are using Alexa as a product and giving them a feedback mechanism thing, which Farooq also mentioned in his thing. So to be very frank, sir, these kind of products are having a better market today than the clinical product yet. So our clinical product buyers are less. Our open product buyers are more, sir, to answer you there.
Yeah. Anantapurna, sir, can you hear me? You're able to hear me, sir?
Dr. Buba, would you please call sir, in case to connect with the panel?
Sir, I think probably
There's some
audio
technical problem. Yeah.
Hear us, sir, but you can hear us.
Yeah. Diksha, can you come in and let us know about the non-clinical areas in technology?
Sure, Doctor. I think that is also one area that I'm really passionate about, or like I get excited about, right? Because when I entered into healthcare industry, what I realized was there were so many areas where other industries were taken that as a given, right? For example, customer satisfaction, overall, like just the customer experience is a huge focus in other industries. Whereas here, when you come in, all the focus was on the clinical parameters, right? How are the doctors, how are the nurses, etc. But there is so much more to it for a patient. So one of the things, I'm not even looking at complicated technology, I would say, when it comes to the non-clinical part of it. So one part I would agree with Dr. Masood is when it comes to billing, right? Just basic communication about the right billing amount for a patient's diagnosis. So currently when it comes, the doctors tell their own fees, or the nurses give an amount which doesn't match with then ultimately what they end up with. So Dr. Masood's product is one thing that we've actually implemented here for us to predict in the starting itself to say, hey, if you're a male with diabetes who's coming for total knee replacement, your average length of stay is probably around 4 to 5 days, and your cost is going to be probably around so much to so much, right? So you're preempting and sort of communicating appropriately, which later then doesn't lead to any sudden shocks. Some of the other simpler things I would say is just basic ticketing system, right? Like your request management. So when requests come, currently a lot of nurses do the request management. When people are admitted within the hospital, the immediate go-to person for any patient is the nurse. So the patient goes to the nurse and says, hey, my blanket is torn, or hey, my TV is not working, or my bulb is not there, right? But that's not the job of a nurse. And to get a maintenance guy everywhere there is going to be tough. So then having a system where you're able to sort of call and tell, and someone's tracking, within how many minutes do you need to address different requests, goes a long way in improving patient satisfaction when they're within the hospital. So these are some of the things. And the last one is communication, right? So right now, all patients are completely comfortable with WhatsApp as a communication channel and all of that. So what we realized was our agents in call center, they were very busy always, and the complaint was that we keep trying to reach a hospital and it's always the number is busy. So then we implemented WhatsApp as a communication chat channel, and immediately we saw then drastic reduction in the number of call drops, right? People then chat and say, I'm looking to get my report, and then we sort of address it and we give. Or they say, I'm not satisfied with this, or I need to understand what do I need to do. Can I get a vaccination? When can I come? What do I get? So everything then becomes through WhatsApp as a communication channel, which people find really easy to use. So these are some of the basic technologies, I would say, which goes a long way in improving patient satisfaction when it comes to their overall health management.
Yeah, that's nice. I just have one small reservation when we talk about WhatsApps in healthcare. I have a serious issue about the confidentiality of the patients about using WhatsApps, because you will not be able to restrict it to any sensible levels. It's excellent tool for communication internally in a hospital setting, but that's the one tool actually can just take your most confidential internal processes. Just it could be the serious cause of trouble for any hospital. And especially in today's scenario where anybody can take a picture and puts on a WhatsApp, and then it goes on, just gets out of your hands in no time. So I always tell the teams to be very, very wary about using WhatsApps. I think that's where the technology should come in. We should have something which is probably encrypted within the hospital's HIS, so that it cannot go out of the hospital in terms of the chat communication that you can actually do within the HIS only. That's very, very important. The reason why people use WhatsApps is because we don't have any sensible internal communication tools as versatile as WhatsApp. That's the reason why people actually resort about using WhatsApp. But I think it's an excellent point.
Actually, within the hospital, we've sort of banned WhatsApp, so to speak. So there should be no official groups for communication in WhatsApp. So we use Slack and other channels, and we restrict communication on WhatsApp only to patients, through chat bots and all of that. So absolutely with you on that, Dr. Mahesh.
Ms. Farooq, can I request your opinion on non-clinical care processes and technology?
So yes, sir.
Non-clinical care processes and technology. What's your take on it?
In terms of using AI and other types of health technological advances,
or even you can use the not IOMTs but IoTs to actually use take care of the non-clinical care processes.
we do that. We've got both for clinical and non-clinical. Like Deeksha was saying, we've also got an AI bot on our website that actually helps patients with their appointments and most of the stuff. It gives them a feeling of interacting with the person really. And it's actually pretty smart. I mean, you ask him for parking or your lab reports and he'll understand, and the bot gets back to you, routinely. So that is one of the things that we've done.
Yeah, we can hear you actually.
Perfect. I was also talking about using technology to connect, patient feedback at various touch points. All right. So we've got an overall tool that sits on. It's from THB. We use that for patient communication. So all of that is automated, actually, both clinical and non-clinical. All right. Based on that, we've actually formed some systems. I mean, we've created something called the discharge bundle. It's not technology based, but there are 2-3 things. One is we've taken into consideration that patients have to be involved in their care. So I mean, when you go into one of our wards, you'll see a whiteboard there, and it will be written to who your team is. I mean, who are the nurses who are going to deal with you? Who are the doctors who are going to be dealing with you? There's going to be another row of what needs to happen. What are the tests that need to happen, today? Then there's another column which says what is expected of you, which means you need to walk 2 times to the toilet and come back. And you need to ask this doctor about this particular report. We try to involve them as much as possible in their care as well. I've got a picture of that. I can maybe don't have it handy. I'm sorry. But it's nice actually, and that has actually created a decent way in which people tend to be more excited. I mean, people want to be part of their care these days. I mean, there are some people who go to Google and then they've got all these diseases in their heads that they have. But leaving them aside, I'm talking about people who are actually inside because their family members are there. And this population is pretty educated, very impatient, and want everything on demand, thanks to all the other industries. I mean, if you want a movie, there's no 1 week waiting. I'm going to go to the OTT platform, watch all the seasons like on a binge, So people have changed really, and they want everything like that, and they expect that from healthcare also. So smaller things are in terms of experience also. I mean, in terms of billing, in terms of feedback. I mean, what we saw was when we started taking feedback at various touch points, it gave us an exact idea as to where the pain points are for the patient. And we've got a system where if the same patient is coming back, the system will actually alert you saying, this guy has come down, he had a problem with the radiology. So, there'll be 2 people waiting there in radiology just to make sure that this time his experience in radiology is not bad and it's actually good. So, they feel happy about that. And they think that, we've had a complaint and somebody's actually done something about it. The other thing that I was saying is we've got this interesting concept of treating the hospital more like a wellness center also. I was saying that in my talk actually. So we started giving out pre-COVID, of course, free Zumba classes, free yoga classes for anybody who wants to come down, marathon training, cycling. I mean, we had a cyclothon coming up. So we had a 100-day cycling training. And then if people wanted to go to the cyclothon, they could go. And if they start performing well, we started rewarding them, even for patients who are in the hospital. So we monitor them. And if they're actually getting better, for example, if they are maintaining diet or if they are staying active, we reward them. Typically, we give them points which they can use in the hospital, revenue coming back to the hospital. But then what happens is there's a trust that forms between patient doctor, patient hospital, but that way I think it's worked very well. But more of in terms of non-clinical areas, when patient wants to come in, these days when you go out to a lab, and they will email you the medical reports. You go in the morning, they'll say, sir, neenga veetukku ponga, naanga mail anuppirom. That's the basic idea, even if you're going to a lab. But some of the hospitals still don't have that technology. And so that is something also which is a bit shocking for patients who are walking inside. So technology in terms of making things easier. Actually, WhatsApp Business, a lot of people use it, sir. I agree with you that WhatsApp has its own pluses and minuses there, but it's been extremely useful. I mean, when you see patient interaction, when we saw more than the online bots, the WhatsApp bots went way above actually. The numbers just increased. I mean, people were extremely happy to do it on WhatsApp. I think that's because of the other industries. I mean, you buy a ticket on ClearTrip and they'll send you your ticket on WhatsApp. And they're used to that. You buy an insurance, it's there, right there back on, on WhatsApp. So they want that here as well. And when they get that, I think they get all excited about it. For them, it becomes extremely easy. I mean, I would prefer that. I'll also want an email, really. So yeah.
I'm not trying to take away the advantages of the WhatsApp or the versatility.
No, but I still agree to where you're coming from. I agree.
Yes.
I agree with you.
I always say that the become more faster and probably I think we prevented many more acute situations using WhatsApp. That's 100% sure. I get very yeah.
Yes, sir. We can hear you, sir.
Salam sir, is it time? Should we conclude?
Sir, we also have Dr.
Hello.
John in the panel.
Yeah.
Yes, Dr. John
Hello.
is in the panel, sir.
Doctor, Salam sir, should we continue or should we conclude?
10 to 15
Hello,
minutes.
Dr. Mahesh, are you able to hear me now?
Go for.
Dr.
Sir, Ananthapadmanabhan sir, I can hear you now, but we can't see you. I think your video is not on, I guess.
Dr. Mahesh. Yeah, thanks. No. Yeah. Now I just relogged in. That's why. Okay. Sir, quickly about your question on non-clinical IT applications. You got.
Yeah, that's
there are
right.
3 applications I thought in here. One is discharge monitoring. When we discharge the patient, people complain that you took about 7 hours, 8 hours, and things like that. So we have developed a system where you can track all the advice charges from the time they went to the time the bills are closed in laboratory, closed in food and beverages, closed in pharmacy, maybe closed in billing. All that we give some kind of a visibility even to the patient. It is something like when the material is dispatched, when it is in transit, when it has been delivered. You can give that kind of information to the patient. So it is very convinced that this process is happening and he does not go to the wards to nurses. That is one thing which we have done, and we have been able to reduce the discharge time from almost about 5 hours to about less than about 2 hours. I mean, assuming that the insurance bills cleared in time. The second is a very interesting application. Hospitals, we have 300 inpatients and you have 300 attenders, and for all those people we deliver food in the rooms. So what we have to do is we have to use this application. So that's the waiter takes the food from the kitchen. He maybe an icon, and then it says that he has left the kitchen. Then once he arrives in a particular floor for delivery of food, he just again presses a button there itself, and then everybody knows that he's there. Then once he returns, he hits the button, and that's it. And so the entire trip is tracked. So if there are about 8 waiters in the food service area, we know how many trips, when did they start, when did they arrive at the floor to come back. So we are able to optimize the utilization of the waiters, and we are also able to track the timings. We are able to, and next to which is very, very interesting, many hospitals, I don't know whether they're doing, we have patients, we have outpatients who move out of the house, move out of the hospital, and we need to track them. We need to call them. Maybe what they do is they just send an SMS message and then call them. But I think the technology enables you an SMS message. but to keep a track of them up to the time you arrange for Ola and Uber to get them into the hospital. So I think the review follow-up extremely important, and this technology is very useful because we get about 400 outpatients in a super specialty hospital. Definitely there is a lot of follow-up, and for each of the day, each day there are about 400 patients who come, and this is done through technology, and humanly it is very difficult to make a note, integrate it with our do it with. I think this really enhances the experience of the patients in the hospital.
Thank you so
I don't
much.
know
I
if
think
I was
no, thank you so much. I think we could hear all the three areas that you're talking about, sir, in spite of some constraints. But we were, I think, thank you so much for bringing in that excellent thought processes, the areas that are there, sir. Dr. John, good afternoon. Dr. Mahesh here.
Hi, good afternoon, Dr. Mahesh. I just wanted to check with all the panelists, especially Ms. Diksha. You know, there is a saying in the MBA program that culture eats strategy for breakfast. And culture also eats technology for lunch, right? So what is the importance of culture when you're trying to bring in, as Dr. Mahesh was talking about, value-based healthcare in a setting where we are all concerned about volume, and Dr. Mahesh was mentioning the fight with the director of finance, where it's essentially volume. So where would you put the concern about culture of healthcare vis-a-vis how technology could enable a kind of a value-based patient care culture?
Sure, Doctor. Thank you. Thank you for that question. I think that's a very valid question. If you ask me, I think it needs to be, you rightly said, right? Culture eats, technology for lunch, I would say. That's because it needs to be in the DNA of the organization of what matters to you, right? So how much ever technology you bring or products or services that you bring, until and unless the overall employee group feel that this is what matters to management and sort of take it up and actually execute, it's going to be very tough to implement any technological solution that you bring in. So for example, when it take just clinical triggers, right, for adverse events, etc. So that is something that focuses on then reducing the overall length of stay. And all the employees believe that that is what is needed, because that is what comes down from the top, and that is what is tracked and monitored, and hence everyone's sort of in alignment with what actually matters, right? So I would say the culture, what is the indication that the top management gives to the employees? What do they say matters? What do they actually track? Right? Makes a long way into what the employees feel is important, which then translates to which of the technological solutions are easier to adopt. I would not say that we can use technology to change the culture. I personally, I don't think that might be possible. I think culture is important if you have to implement the technological solutions.
Masood, do you think AI would help us in developing a culture which Diksha is talking about?
Technology in today's life, we all say that, all our kids growing at home, they said they've been spoiled because of technology. So the culture and technology, in my opinion, is vice versa. So if you bring this up, something goes down, something comes up, something goes down. Can't have both anything. We can try to balance it probably. We can, because our culture is very important to us, because we have grown with values. Values are important. So what is actually driven our culture is basically the values only, So if you have to just put the values inside your kids and the environment and people around you in whichever form, whichever way you are, I think we'll be winning over. Holding the culture sometimes might be a little tougher. People might resist to come out a little bit. Same time, technology is also important for faster driven approach, going forward into it. A right balanced approach is what I could recommend, sir.
Right. What was very reassuring from all the panelists was that you don't seem to be taking a dim view of singularity, right? If you look at Kurzweil says that come 2029, artificial intelligence and machine learning will take over the human intelligence, and come 2045, human is not required at all. Machine will do everything, which stuff. Whereas my view is very optimistic, and I believe that whichever technology you use is essentially enhancing the human wellness and human welfare. And that's where singularity needs to be used in a way where what we are concerned, and all the panelists have talked about how do we improve the patient experience, how do we improve, as Ms. Diksha talks about, not bring the patient back to the hospital, but take care of many of these things. So I believe, unlike what Kurzweil thinks and the wrong interpretation of Kurzweil's singularity, I believe that all this technology could be used to enhance both the customer experience, affordability, and I believe that I'm more concerned about primary health care. Look at India. India is 60% of Indians are still in rural areas, in tier 2, tier 3, where access to healthcare is a major challenge. Assurance to healthcare is a major challenge. Affordability is a major challenge. Niti Aayog tells that on an average, 75 million Indians fall back to poverty because out-of-pocket expenses are very high in India. So the challenge for all of us is what to, and Dr. Mahesh hit the nail on the head. Is it the clinical care process which is more important, or is it the non-clinical care processes? How do we ensure that those who can't come, because again, I will quote another Niti Aayog study which says that on an average in rural India, patient has to travel for 50 to 75 kilometers to access a health care. So I guess that all our discussions are very urban centric, where there is very articulate patients. Think of the poor patients in the rural area. What kind of technological interventions would help us to bring them in together? And that's where the telehealth and some of the stuff which Jayakant was talking about, not creating a smart ICU, but creating a, and his definition of ICU was that digital and smart processes which allows patients to feel that they are taken care will go a long way. Telehealth in terms of smartness. So I believe that when you are a listener, Dr. Mahesh, you learn more rather than when you participate. So I have learned quite a lot today. I'm an enlightened person because I believe that all teachers should be seekers of enlightenment. And I thank Dr. Booma and Dr. Nitya for organizing such a wonderful panel discussion with a great practitioner, Dr. Mahesh, coming in and providing the guide rail for the discussions. This is marvelous, amazing experience. Thank you very much.
Thank you, Dr. John. I mean, in fact, that's what I opened my when I started talking. I said that's what I started saying. You know, I'm more to learn here rather than to be listening by listening to the elite panelists, because it's always pleasure to learn at any point of time. You know, I'm sure
Absolutely.
I learned a lot from. I mean, many times when I hear Anantha Padmanabhan sir, he always comes up with saying, not in this panel, I heard him talking in many other areas. Today I heard, learned so much from Dr. Masood, Dr. Muhammad Farooq, and Diksha. Thank you so much for all of us being here, for all of you being here. Thank you, Dr. Booma ma'am and Nitya ma'am, for, and of course, Selam sir, for pulling me into this. Normally, I try and stay out of any of the non-medical panels, usually. I don't usually be a part of management, though I take care of the management, the administration, and hospital issues, but I try and stay away as much as possible. But thanks, Selvam sir, for pulling me into this, because I have very strong opinions about patient outcomes and safeties. So I am very centric about it. As Mohammed said, like, you know, we somewhere down the line we lost being patient centric, in my opinion, in our eagerness to grow, in our eagerness to treat more number of patients, in our eagerness actually to embrace, as Dr. Vikram said, embrace technology. We should not lose the sight of patient centricness. To me, that's a major problem that we have right now across. You know, just because the technology is coming in to answer, in my own thought processes for Dr. John's statements about culture and technology, I think it's organizational behaviors that we need to start working on, about what is your core values that you are actually trying to look and focus upon as an organization, so that you don't get out of sight with your technology, and make sure that your technology actually focuses on your organizational values, and ensure that what you are there, your mission, your vision statements are in alignment with the technology that you're embracing. Ensure that it's all in place. Thank you for John. Thank you, Dr. John, for coming in and then being here. I'm back to Selim sir to close this panel.
Yes, Dr. Buma, we can move on to validation. Yeah, make it shorter.
Smarter.
Yeah.
I thank all the members of the panel for sharing your knowledge and experience with us. This session was very insightful for us. We are getting closer to the end of our time together. I would like to call upon Ms. Nitya Priya, Assistant Professor, Faculty of Management Sciences, to deliver the vote of thanks.
A very good afternoon to one and all the dignitaries present here. It gives me an immense honor to deliver the vote of thanks on this insightful event. First and foremost, my sincere gratitude to Honorable Chancellor and Pro-Chancellor for their grace and support for Healthcare Technology Summit 2021. I express my sincere thanks to the Honorable Vice Chancellor and Dean of Faculties for sharing their knowledge and for the continuous support and encouraging them throughout the program. My sincere respects and thanks to our energetic director, Dr. K.C. John, Faculty of Management Sciences, for his continuous encouragement and inspiring us in all the way possible. No event can take shape without a leader. I express my gratitude to Dr. Salvam Jasaya, Principal, Faculty of Management Sciences, for his continuous support and motivation for organizing such amazing events. We have been fortunate to have the renowned identities from academics, healthcare, IT, and other areas. I'm very thankful to the entire dignitaries, Dr. Maheshwar Kamadi, Mr. UK Anantha Padmanabhan, Dr. Masood Ikram, Mr. Mohammed Farooq, Mr. Jaykant, Mr. Ashwin, Ms. Deeksha, for giving an excellent coverage on leveraging technology in transforming new healthcare delivery system. Also, I would like to place on record my deep appreciation and sincere gratitude to the organizing committee, faculty members, my dear students, participants, and communication department for making this event a grand success. Thank you so much. Take care.
Thank you so much.
Thank you.
Dr. Masood, Dr. Anantha Padmanabhan sir, Dr. Mohammed, fantastic input. Even makes us to think of, you know, is there any new things that we can incorporate in our curriculum? We have our own regulatory issues, but we want our curriculum to be revamped every semester. So great input, sir. Thank you so much. Yeah.
Thank you. You're very kind, sir. Thank you.
Thank you all so much, sir. Can we all give a smile so that I can take a snapshot?
Not only smile, but I guess that this is the beginning of a relationship and experience. And what we look forward to is continuing engagement with all the panel members. We want to prepare managers who are future ready, who are industry ready. And you are in the cutting edge practice of bringing technology, changing the culture, bringing together the patient experience together. You know, that these are all the stuff which we want to build into our curriculum, into our experience of MBA. So what we would look forward is not to end the relationship which we have begun, but look forward to inviting you to come over to our place, engage with our MBA participants, and then maybe some of our MBA participants would come over to your place and do some internship. We have a very strong program of doing empirical dissertation. And that's one area where we encourage our MBA participants to kind of immerse in some of the organizations which you are leading, where you are working, so that they can learn experientially, so we are moving away from lecture-based education to experience-based learning and problem solving around areas which are very germane to you. So we will come back to all of you, identify areas which are very important to you, and then we will bring our students and work along with the student to see if we can find some solutions around that. So I'm pretty excited. This panel members, we want to look forward to a continued engagement and continued work in terms of building the future-ready healthcare leaders. Thank you so much.
Thank you, sir.
Mr. Tiksa, you have done a fantastic
Thank you,
job for the summit. Yeah, our participants are highly benefited. Thank you. Thank you so much. Yeah.
Thank you. Thank you.
Thank you so much.
Great.
Thank you.
See you.
Thank you, sir.
Thank you all.